get started. So first of all, I know that you all are aware of Progressive Aligners launch, but for those of you who maybe haven't heard a lot, I want to just reintroduce it to you one more time. If you can see my video, we've got our little Progressive Aligners patient box right here. Looks very nice. So Progressive Aligners, we're very excited about this new product. We've worked really hard to partner with a manufacturer who are top of the line, literally the best available out there. And we've really geared it to be specifically designed for you, the general dentist. So it's a web-based software. There's not an app for your phone. This is something that is a web-based software. You'll go and upload cases and things on your laptop. We have a very nice website that has both a doctor portion that you can go and find information about, and also an area for patients if they want to go and check it out. That's progressivealigners.com. We encourage you to go check out the website and what content is there. From that website, progressivealigners.com, you can click on Doctor Portal and it will take you to our Doctor Portal login site, and you'll just use your SmileStream account information. So many of you already have a SmileStream account and are active on SmileStream. So just put in your SmileStream username and password and it will take you right into your Doctor Portal. And if you don't have a SmileStream account, just go ahead and put in an email or put in an email address and password, and then we'll be in touch with you to help you set up those accounts. If you're in SmileStream, we've added some buttons to SmileStream to give you direct access to your Doctor Portal without having to go through the progressivealigners.com. So you'll see two new buttons. One is over here on the left-hand side in the orthodontic module, and one is up on the top of the screen. Either one of those buttons will take you directly into your Doctor Portal workbench area without having to re-enter passwords. So it's all nicely done and integrates with SmileStream. You'll still have to upload photos and STL files into the Progressive Aligner website, into the portal when you submit a case. It's not going to populate from SmileStream yet. Hopefully we get that functionality at some point. Pricing is really good. The retail price is better than I think anything that's a good aligner that's out there. And so this is the retail pricing for these different products that we have. There's a Progressive 10 for very simple cases, Progressive 20, Progressive 30, and an unlimited. Most of you will be using the Progressive 30 and the unlimited on most of your cases. And I think the best way to submit a case is to just choose the option that says, not sure. You can choose the product after the treatment plan is provided. It says choose product after treatment planning. By clicking here, this allows the designers, the stagers, to complete your treatment with the ideal protocols, moving the teeth at the rate that is the most predictable and efficient. And if we say, you know, we want a 20 product, they might try to fit the treatment into just 20 aligner stages, and it won't be as predictable. And so if you click the choose product after treatment planning, then when you get the setup back, you'll be able to look at it and say, okay, this took 25 aligners to get to the endpoints. And so I could choose the Progressive 30. You can, when you go to approve the case, you can then choose which option you want. There are some nice things about going unlimited, not worrying about having to pay for any additional refinements or revisions needed during a 5-year period. Whereas the Progressive 30 product gives you 2 refinements of up to another 30 aligners each, but there is a limit there to the 2 refinements, and the warranty period is 3 years. So you might find that the extra money is worth having that security, the insurance of knowing that you can get unlimited aligners until the case is finished. The finishing product is unique to Progressive Aligners. And this is really great because many of you are doing braces and you know you get to the point where you're ready to get the braces off. There's little things that still aren't perfect. You'd like to get it perfect, or the patient's just tired of the braces and wants them off and you still aren't finished, or they have a wedding or they're going off to college and we need to get the braces off, but we'd still like to do some finishing. So if you bought your brackets through Progressive Orthodontics, if you have the IP appliance, then you're eligible to use the finishing appliance, which is discounted to $500 and has 10 stages, 10 aligners, and then a set of retainers at the end of it. And so 10 aligners lets you do some nice finishing on a case and then gives you a retainer at the end. So that's a really nice option that's not available through any other aligner company at this point. I'm really excited about this. You know, as a GP, it's difficult for me to, well, I'm not able to, at the volume that I do in my practice, to hit the discount tiers that are available to the orthodontists with other aligner companies. You know, so the orthodontists that are doing large volume are getting really good discounts on their cases because of their volume. And I'm just not able to achieve those levels or advertise myself as a platinum or titanium or elite provider. So here, you know, if you're doing, this is a 6-month case start number. So every 6 months, it'll be reevaluated. And if you're starting one case, you know, every month, which is not very many, that automatically puts you into the premier category with a 5% discount. If you're starting 2 cases a month, that's right in the elite, but almost, you know, one more case over that would put you into the platinum, where you're getting a 15% discount on your cases and a platinum level provider. So, you know, Miles McGann, our CEO, has really tried to shape this product so that it's best for you as the GP and give you discount volumes at a level that's attainable for the GP. What I'm really excited about, and I know Don's really excited about, is the fact that the designers, the stagers, the technicians, whatever you want to call them, the people behind the scenes who set up our cases, are the best in the industry. And, you know, what makes an aligner case work well or not work well? The first thing, obviously, is the patient compliance. They have to wear the aligners or nothing's going to work. Even the best setup is not going to work if the patient is not wearing the aligners. But if the patient is wearing the aligners, the next thing that really affects the outcome is, how was the case set up and designed? How were the teeth staged and moved? Is it predictable? Is it appropriate? You know, are the protocols followed that are going to make this work for the patient if the patient's actually wearing the aligners? And the stagers, the designers that we have, they're dedicated to our doctors, are the best in the industry. They've been trained for a minimum of a year before they're able to even take a case. And in most other aligner companies, they're in there for a week or two and they're already taking cases. And so these designers are retained for long periods of time. They're highly trained. They understand orthodontics really well, orthodontic terminology. They understand what we're saying when we're trying to communicate with them about the case. And they'll even look at radiographs and photos that you provide and give some insight or suggestions or do things in the setup that will complement what they see in the radiographs and the photos, rather than just focusing on straightening the teeth. So that's my favorite part, is how good, you know, and everybody who's switched over from one of the other aligner companies to this one and gotten a setup back has been so impressed with how good the setup is, and how sometimes they're accepting the very first one they get back because it's great, or they might do one small change and then accept it, versus, you know, 4, 5, 6, 7, 8 iterations back and forth with the technician to finally get something that we are willing to accept. The materials are amazing. It's a really nice aligner, really nice material, top of the line, really good torque control, rotation control. And we do have the option. It comes normally in the scalloped trim line at the gum line, which is nice. It's comfortable for the patient. But if we want a case where we want to request a straight trim line trimmed a couple millimeters above the gingival level, we have the option to request that in our notes when we submit a case. So if you have a more complicated case with more torque sensitive movements, or maybe smaller clinical crowns, and we want, or maybe we don't want to put engagers on the teeth or attachments on the teeth and try to use fewer attachments, you could request a case to have the straight trim line. And we can even request posterior only being straight or anterior only being straight. And so there's lots of flexibility there on these trim lines, but it's a very nice aligner product. I'm going to show you the software today in our presentation. You'll be able to see some videos from the software. It's really nice software, top of the line. All the tools that we need to communicate well and evaluate our setups. Nice 3D doctor edit tools, all very intuitive and easy to navigate and use and evaluate your setups. It looks nice for the patient when you're showing your patient the case setup. We have all the good features. Great selection of attachments. We have bite ramps on the lingual surface of the aligners, torque, intrusion, rotation ridges. We have button cutouts, so you don't have to do that yourself. We have everything that you would need or want, and we'll be talking more about these different features. Don and I will, as we go through these webinars and we talk about cases. So let's jump into some concepts that we want to clarify a little bit and get into your mind before we actually look at this case, so that some of these things make a little bit more sense as we look at the case. So first of all, the way that you get orthodontic cases is to talk to your patients about ortho. Have somebody in your office, your staff member, somebody who's on your team using aligners so that they are excited about it and your team is excited about it. And you can generate some talk, some verbiage in your office of everybody being excited about this. And every one of your patients, you should be asking, have you thought about straightening your teeth? And whenever I ask that question, even if it doesn't lead to orthodontics, it ends up leading to cosmetic dentistry. And so you can really generate some great conversation with your patients just by asking, have you ever thought about straightening your teeth? Okay, so we have to be asking the questions so that we generate people who are interested in doing ortho and letting people know that we're doing ortho in our practices. And if we're doing brackets, some of you are only doing aligners, but if you're doing brackets, some patients will accept and use brackets. We still believe in brackets. Brackets are, in my opinion, still the gold standard for getting the absolute best finishes on cases. But Don and I both are very excited about how good the finishes are that we're getting from clear aligners, and especially this product, progressive aligners. Some patients will only accept clear aligners. And so that's the reason why we want to offer clear aligners in our practice, is because, all the advertising that's out there, patients are getting a lot of information telling them that, braces are the old way of doing it, that aligners are better, that it works better. And whether it does or doesn't, it makes sense for us to provide clear aligners in our practice. There's lots of patients looking for this treatment. Just like with our bracket cases, we're going to want to get a set of full records. Okay. We still need a lateral ceph, even if it's an aligner case. That's a standard of care. And panoramic X-ray and photos of the face, intraoral photos, intraoral scan. Okay, want to iterate that scanners do give a better fit of the aligner. And remember, aligners move teeth by pushing on them. We need to have intimate contact between the plastic of the aligner and the surface of the tooth. And the more intimate contact we have, the better it's going to be able to move teeth. And so intraoral scans do give more detail and more exact fits of the aligner compared to PVS. But if you don't have a scanner yet, and stay tuned, we have some great things coming out next year that will involve simulations that we've partnered with Medit, and Don's been working on with Miles for several years now, and you're going to really love it. It's going to be very exciting. So you will probably eventually want to have a scanner. But if you don't have a scanner yet, you can still take a PVS impression. And if you go to the frequently asked questions in the doctor portion of the Progressive Aligner website, you'll see some information there on how to convert your PVS impressions to an STL file. You can use myOrthoselect.com. OrthoSelect will help you convert that to an STL file so you can order these aligners. You've probably all heard about coaching. Coaching is available and appropriate for aligners. We still have consulting and mentoring. Okay, so just briefly, coaching is a free service to everybody who wants to use it. It's available through SmileStream. So when you have a patient uploaded into SmileStream, there's a new button that looks like a whistle, and it's next to the consulting button, and it says coaching. And if you click this button, it will either take you to the coach that you've already been assigned to, or you can pick a coach. And it basically is just a way of sending for kind of like a free case check, like what we would do at a seminar in person, go up and show the instructor your case and, hey, is this a good case for me to treat? Or if you were to email or send the case as a SmileStream member or colleague to a consultant or mentor and say, hey, before I pay for the consulting or mentoring service, can you just see if this is a good case for me? Here's my background. That's what coaching is. It's to help you determine if this is a good case for you to treat based on your education level and experience level, and also maybe help you understand a little bit about the case and whether it's a good case for aligners or brackets. So all of you can use coaching. That's available to all of you. It's a free service that comes with progressive aligners. But we still have the consulting and mentoring service that you can get through SmileStream with the button that's always been there, the coaching button. And consulting is still basically looking at all of your records, diagnosing the case, coming up with a treatment plan for you, helping you understand your case, giving you a list of instructions on how to submit the case to progressive aligners, how to answer all the case submission questions, what instructions to give to the designer. And then when you get your setup back, to help you evaluate the setup and make sure that it's done appropriately, and that there aren't maybe any changes that we could do to optimize that setup. So that's what consulting is. Mentoring is helping you through that case until you're finished. So mentoring, you can continue to get questions answered along the way about the case. If something's not tracking or not working well, and you need to do a revision, the mentor will help you with your instructions for the revision and will help you evaluate those revision setups before you approve them. And you can always upgrade from a consulting case to a mentoring case later. So we still have those services. Coaching is just a new free service to help you at the beginning of your case to decide if it's a good case for you. In the Progressive Aligners Doctor Portal software, it's your workbench. It's where you go to see the cases that you've submitted or to submit a case. Remember, you are going to create an account by using your SmileStream username and password, like I already discussed. And then going into that portal and submitting, uploading the photos of the face, the intraoral photos, your lateral ceph, your panoramic x-ray, your scan. Any scanner will work. You don't have to have a particular brand of scanner, okay? Any STL file that has the bite will work. And then you're going to pick your package like I discussed earlier. And I like the option of waiting to decide which package I want after the setup is done. Okay, we've already got clinical preferences installed for you that we think are ideal for the GP, but you can always go in and change your clinical preferences if you want in the doctor portal for Progressive Aligners. In the manufacturing process, okay, they're going to quality check to make sure that the intraoral scan is complete and the bite is correct. Sometimes you'll get a message back saying, hey, there's a problem with your intraoral scan or something's not lining up right. And you need to go and redo the scan or get new impressions and make sure that we're starting with accurate information. And we're always going to want to check that when we look at a setup. We're going to want to make sure that that it looks right, that the teeth look right, that it matches the photos, that there's not something that is that's inaccurately represented, and make sure that the bite looks right, that it's been articulated properly, and that it matches the photos. Okay, and then we're going to evaluate the 3D setup that's been prepared by the technician or designer at the other end. And when we're happy with it, when we have made any changes or any modifications that we want to, then we're going to approve the setup, okay, after we've submitted any modifications. And once we've approved the setup, that's when we get charged and we make payment, and that's when the manufacturing starts. Okay, and that's when, after the manufacturing starts, then the aligners will be shipped out. So realize that there's going to be a period of time between when your patient says, yeah, I would like to do aligners, and when you're actually going to be sitting down and delivering the aligners for the patient. Okay, I would plan on probably 3 to 4 weeks, depending on whether you use a consultant or mentor, how long it takes them to do your case for you, how many back and forths you do with the designer technician before you approve the case, how attentive your patient is to coming back in and approving your setup and saying, yeah, that they're happy with that. So, I mean, there's different things that will affect how long it takes, but there is some time in manufacturing and shipping of the aligners as well. So just make plans for that and be aware of it. When we get the trays, when we get the aligners, we're going to go through the instructions with our patient. There is a nice little patient instruction pamphlet, little booklet inside of the patient kit. But we're going to explain aligners to the patients, help them understand how the teeth are moving, help them understand that there needs to be a force present on the teeth for 22 hours a day in order for the teeth to respond and move. Okay, so help them understand that when there's a constant pressure applied to the tooth, that initiates changes in their body. It causes the cells inside of the bone to wake up, the osteoblastic, osteoclastic activity to start to remodel the bone. And if that force isn't there all the time, then that's not going to turn on and you're not going to see teeth moving, or it won't move very well. So we want to help them understand that they need to have these aligners worn 22 hours a day so that the force of each one of these different aligner stages is being applied to the teeth over a long period of time. Show them how to put them in. Make sure that they know how to remove them. There's a nice removal tool included in the patient kit that they can use to get the aligners in and out. So help them get them in and out of their mouth. Make sure they're comfortable with that. Stress the 22-hour wear time. Stress keeping the aligners clean. Okay. I always want to make sure that my patients put the old aligners that they're finished with back into the bag that they got them out of. Okay, because sometimes if things aren't tracking well, I like to go backwards an aligner set or two and get back to one that was fitting well, and then move forward from that one. Okay, so have them keep their old aligners. I even like them to come in with the previous couple of sets of aligners so that if things aren't fitting well, I can see the previous ones. So when I have my patients come in, I want them to come in wearing the aligner that they think they're done with before I give them new ones, and bring the previous ones with them, you know, the previous 2 or 3 sets, so that we can see them if we need to. Okay, I'm going to talk about aligner when we change the aligners in another slide in just a minute. So I'll skip over that part right now. I like to encourage patients to keep the aligners in all the time except for their major meals. Okay, so remove them if you're sitting down to a major meal, like you're having breakfast or you're having lunch or you're having dinner. And then after the meal, brush your teeth, rinse your mouth, get your teeth at least cleaned up a little bit, and put the aligner back in. But leave it in for drinking, leave it in for eating snacks. 2 reasons. One, the chewing process on eating snacks does help to kind of settle the teeth into the aligner, just like the chewies. But also just the amount of time that if patients are pulling the aligners out all the time for snacks, it's just another reason for it to be out. You know, it's like when you're fishing, if you're always pulling your line out of the water, you're just not going to catch fish. It needs to be in the water. And so the fewer reasons they have to take those aligners out, the better. Set some expectations, especially for your adult patients, that there's going to be some discomfort, some irritation, that getting through the first, 7 to 10 days might be a challenge for them. And they need to reward themselves to get to the point where having those aligners in feels normal. It feels like having shoes on. You don't think about it anymore. And if anything, you kind of feel like your teeth are naked when they're out. That's what we're shooting for. But they might get a little bit of irritation on the inside of their lips. The teeth might get a little uncomfortable. The gums might get a little bit of uncomfortable as these pressures are being applied. And they might need to take some ibuprofen or Tylenol just until they get used to the aligner wear. They might find that they salivate a little bit more, that they have to, read a book out loud or something to kind of get used to speaking around these aligners. That's pretty normal for starting an aligner case. Okay, help them understand that they need to brush their teeth and the aligner. I think that's the easiest way to clean the aligner, is just simply when you take it out, just brush the inside of the aligner and keep it clean. Okay, and we'll talk more about this. I know I'm going through things fairly fast, and I can't teach you the whole entire aligner education in the 2 hours that we have, 2.5 hours that we have together. So I know we're going fairly quick through this, but we just at least want to touch on these things briefly, okay? When you go to deliver the aligner the first time, you may need to cut back any undercuts. So if you have any seating problems, if it doesn't want to seat down somewhere, you can look at where there might be an undercut, and you can trim that little part out of the aligner to get the aligner to fit initially until the teeth start moving. If it doesn't seat perfectly when you first put it in, there's little chewies, these little rubber, they look like cotton rolls, but they're made out of rubber. Give them the little chewies and encourage them to bite on those frequently until their teeth are seating all the way down in the aligner. And that's a really good practice throughout treatment, is for them to use these chewies anywhere where they can tell that the aligner, like when they bite on it, it has a little bit of a squish factor, like there's a little movement there. They're going to want to bite all the time repeatedly on those areas until the teeth have moved into the aligner, so that we don't change to the next aligner until all of the teeth have expressed the movements of that aligner and are fitting perfectly into the current aligner. There's a question here I see about international. Miles asked me to tell you guys that things are looking really good. I know it's only available in the US right now, but everything has been signed, and apparently either late August or early September is when we're thinking that these will be available in the rest of the countries. Canada, we're still waiting on FDA approval from actually Canada, from the country. But for most of you, things will probably be rolling out late August or early September. So we're very excited about that. Okay, so here's a list of some of the instructions that are inside of the little patient guide booklet. Oh, and pricing, I'm not sure on that. We'll have to, that remains to be seen, as far as, I'm sure it'll be similar to what we have here, but every country is going to have slightly different pricing just based on your area. So that you'll find that out as soon as we can. Obviously, putting the aligners in, use your fingers to seat them. Some patients put them in a little bit and then bite them into place, and that can damage the aligners. So try to seat them all the way with your fingers. You got to get your fingers in your mouth to put them in, and push with the fingers from the front to the back to make sure they're seated all the way down. Use the Chewy afterwards to make sure that they're seated all the way down. And when you take the aligners out, you need to put your fingers into the back of your mouth and pull from the back. That's the easiest way to get them out. So seating them is front to back, removing them is back to front. In the upper arch, it's easier to start on the lingual side in the back. And on the lower arch, it's easier to start on the buccal side in the back because of the tooth anatomy. And, you know, a lot of people are successful by pulling both sides at the same time. So grabbing the insides of the upper on both sides and pulling down in the back on the same time. Or if that's too difficult, you can do one side and then the other side. Okay, so always wearing the aligners except when you're brushing or eating. If they have their aligners out too much, it's going to make them have to wear them longer and treatment won't go as well. Okay, clean the aligners as we talked about. I would avoid drinking any hot water, tea, coffee, especially if you're not using a straw or something like that, only because it could deform or cause decay of the aligner material. And they don't want to clean them in hot water or in any kind of a solution that could damage the aligner. It's okay to put them in like a denture cleaner, okay? But anything that could damage the material, we don't want them to clean it in that. If they were to lose or break an aligner, the easiest thing to do is just move on to the next aligner. And they'll be wearing that next aligner maybe a little bit longer and using Chewies a little bit more to get the teeth to fit in. But usually that's the best solution, is just to go and move on to the next aligner. So as we already said, keep all your past aligners in their bags so that we can use them if we need to in moving forward. Okay, this concept of key tooth is something that we want to introduce you to. Okay, a key tooth in an arch is basically the tooth that needs to move the most in order to get to the final target position. So it's usually a very rotated tooth. So for example, in this arch, in this case we're going to look at today, this upper right one is probably the most rotated tooth. And so the amount of rotation that's going to be required to get that tooth straight is the key tooth. It's going to be the one that determines how many aligners it's going to take. So if we look at that and estimate that it's a 25 to 30 degree rotation, just looking at the patient's mouth, we can probably estimate that it's going to take somewhere around 25 to 30 aligner stages in order to get that fixed, because we're going to rotate these teeth at about 1 to 1.5 degrees per aligner. Okay, so that's what a key tooth is. A key tooth is what is the tooth that's determining the rate at which the rest of the teeth are moving, and how many aligners does it take to get that tooth straight. We are moving teeth at a rate of 1/4 millimeter per stage for linear movements, at about 1.5 degrees of rotation per aligner change. And the same thing in changes of angulation. So moving the root torque, root angulation are moving at about that rate. And realize that aligners are made out of plastic. They're flexible. So there definitely is some inefficiency. And sometimes we need to overcorrect, especially that key tooth, by several degrees on a rotation, for example, in order to get the result that we want, because there can be inefficiencies. Sometimes the inefficiency is coming from the patient not wearing the aligners well. Sometimes the inefficiency is coming from the actual material being flexible. Somebody asked about not having a scanner, and you can convert your PVS impressions into an STL file. And if you go on the Progressive Aligner website under the doctor frequently asked questions, you'll find some information on that. So key tooth, we'll be talking about that a little bit as we go throughout these cases. So one of the doctors that Dr. McGann is working with, that he's been a consultant mentor for, is Dr. Alex Scott. And I think we'll see some of his cases in future webinars as well. But he contributed his experience with bonding attachments. So we want to share that with you, because starting a case, you're going to be bonding attachments onto the teeth. So he said, I would say the technique I've really refined and developed over the past year has been attachment placement. He said it takes longer, the technique he's using, but I really feel like I get good attachment placement. More recently, as I've refined my technique, I realized that poor attachment placement can throw the whole case off. So here's what I do. Okay, so there's a lot of information right here if you want to take a screenshot or come back to this later. Okay, but basically what he's doing is taking the template, putting it in a Ziploc bag with alcohol and running it in ultrasonic cleaner for 2 to 5 minute cycle, 2 5-minute cycles. And he says this prevents the composite from sticking to the templates. Okay, this is a problem with other aligner companies. It's not going to be a problem with your progressive aligner templates. So I don't think you're going to need to do that. But if you've ever experienced the composite bonding to the inside of the template rather than bonding to the tooth and pulling off when you remove the template, that's a solution, but I don't think you're going to have that problem with progressive aligners. I do agree with this one, cut the template into sections, okay? So if you've never done an aligner case, when you open up the box, you're going to have all these aligners to give to the patient, but the first one, or whenever you're supposed to put attachments on the teeth, is going to be a template. It's not an aligner. It looks kind of like an aligner, but it's made of different material and it's trimmed a little bit differently, okay? They're intentionally a little bit more stiff, a little bit thinner material, and they're cut in a way that it doesn't go up to the gum line quite as far. And the reason for that is we want very precise placement of the attachments onto the tooth. So attachments are the little composite shapes that we're bonding onto the teeth to increase surface area, especially in a direction that allows the aligner to push. So for example, a rotation, it gives more surface area to push on the aligner. That's what an attachment is. And so when we place the necessary attachments on a teeth, we have a template that allows us to place them onto the teeth, okay? So you're gonna take that template and you'll have an upper and a lower, if assuming that there are attachments in both arches to place. It's easier to manage if you just take a pair of scissors and just cut right through the midline, just cut them in half. So you have a right side and a left side. So you'll end up with 4 quadrants. And if there's a lot of attachments to place or the teeth are a little bit more crowded, it's even better to cut it, as he says here, into 3 sections. So you have an upper right back, an upper anterior, and an upper left back, and do them in sections like that. Okay, it's easier to isolate and prepare that area and have control over what you're doing in that area rather than trying to do it all for one arch at the same time. So I also agree that you'll do much better by cutting these templates and doing them in sections. Now, this is a technique I haven't used, but he likes to cut some of the lingual or palatal part of the template away, giving better access to the little wells or dimples that are on the facial side so that he can work with that area, which is where the composite is going to go. Okay, so he likes to trim some of that off. And he says this allows for a smaller working area and allows me to firmly hold the template on the teeth with a single finger. So he likes to preload the template with packable composite. I agree that you need to use packable filled composite rather than flowable composite. Okay, because you want these attachments to maintain their structure and their, the really fine detail. You want that to be retained rather than wear down and become not so well defined, because then you'll lose the efficiency of that. So a nice filled packable composite, whatever you use on your posterior restorations, place that into the aligner and then put it in a dark box so it doesn't cure. And he says he usually does this the day before treatment. I usually do it just before the patient comes. Okay, but I agree that this doing this ahead of time is a nice way to do it. He says when the patient's in the chair, I place a section into the mouth. So let's say he takes the upper right side. It's already been filled with this packable composite. It's not cured yet. And he puts it into the mouth and seats it down all the way. And this creates essentially a custom fit pad onto the tooth where that needs to bond. And then he pulls it out and there's going to be basically some flashing. And so he uses an explorer to trace the well and basically remove any excess before he cures the whole thing. So he's doing this outside of the mouth. And he says, that's why I like to cut away some of the lingual so that I have better access to that area. And then he air dries the saliva off the composite so that it will still bond to the teeth. Okay, so then he puts it back away. So now that composite has a custom pad inside of it. Then he isolates the quadrant, etches, rinse, applies bond, dries with a cotton, places a cotton roll. He says, I do not air thin as this makes the bonding adhesive go all over the tooth. I'm going to give you my suggestions in a minute. I do air dry that, but I'm going to go with what he's written here for now. He says the cotton roll technique allows more precision, cure the spot of bond. Okay, so he's drying it with a cotton roll rather than with air. It says place the quadrant or the section that with the prepared pads onto the teeth, light cure and remove. He says it's much easier to remove a section of attachments compared to the entire arch. I agree. When you go to remove these templates, they're a little bit tight and you have to use a sickle scaler to do it. And it's easier to just have like a quadrant or a section rather than the whole entire arch. So not only is it easier to place, but it's easier to get it out. So he said, as I said, this takes longer, but there's very minimal flash at the end. It's easily removed. The attachments are fully formed. There's no voids. You can see all the details and they look like high quality attachments. And this has given me more confidence for the case outcomes. So thank you, Dr. Scott, for sharing that with us. Here is my list. If you want to take a little picture of this or screenshot it. I do similarly, but what I like to do is section the template, like we said, into 4 quadrants or smaller, depending on how many attachments there are or how crowded the teeth are. I like to also fill the little well or the space in the template where the composite goes. I like to fill that with a packable composite and kind of make sure it's pressed in there with a ball burnisher to make sure I don't have any voids and it fills that space well. And then I use the ball burnisher when I'm filling it and packing it in there to remove any excess. And I create a slight underfill from the shape of the ball burnisher. So it's a little bit like a meniscus with water inside of a glass or something, just slightly underfilled. And then I cover that and keep it away from the light, same thing. Then prepare the tooth surface for bonding. Okay, make sure that you use pumice before you bond to the teeth. I even like to use a fine flame diamond burr, especially on like molars and bicuspids, to just expose some enamel that's not hyper mineralized. Okay, give me something that has had a little bit of mechanical roughening to it to do a good job of bonding to that. Etch, rinse and dry, place the bonding agent. I do air thin it, but I think it's fine if you want to use a cotton roll so that you don't have so much of it. Okay. And then cure, make sure that you cure the bonding agent. Don't just go straight to the template. You need to cure your bonding agent. Do not use self-etch adhesives. Okay. They don't bond as well. And so make sure you're using a separate etch and a separate bonding agent. So I etch and then I use Optibond Solo Plus in my practice. There's lots of good ones out there. So now we have the tooth prepared and I have the template filled with the packable composite. And then what I do before I actually put it on the teeth is I put a very small drop of flowable composite on basically the back of each attachment where it's going to come in contact with the tooth. I use Renamel. So that very small bit of flowable composite is what's going to make sure that the connection to the tooth is 100% filled. Okay, that there's no voids underneath the attachment between the attachment and the tooth. So then I put the aligner into the mouth. I seat the aligner or the template with finger pressure on the occlusal surface. And then I take my ball burnisher and I burnish around each one of the attachments. I don't press directly on the attachment because that would squish the composite out of the little well. Okay, but I burnish around it to make sure that it's pressed flush against the tooth. And you'll see that little drop of flowable composite just kind of spread very thin. And now I know it's going to really stick to that tooth. And when you do that, you can even see the air go away from this template, and you can just see that it sticks really tight to the tooth before you cure it. Every once in a while, you'll have a spot where the template doesn't fit perfectly to the tooth. And after you've burnished it, you'll see, and you let go, you'll see the template kind of pull away from the tooth just a little bit. And in those areas, I'll hold the template down tightly against the tooth using that ball burnisher, just somewhere right next to the attachment, not right on the attachment. I'll just hold it there while I do a full cure to make sure that it was well attached to the tooth. Okay. And then I pull out the template with a sickle scaler. And if you have anything that's a non-enamel surface, so you're trying to bond to other composite, or you're trying to bond to a crown, porcelain, or zirconia, or anything else, I like to have this Assure Plus by Reliance in the practice and follow their protocols for each of the different types of material that you might need to bond to that's not enamel. But you guys are all general dentists. You're really good at bonding composite to teeth. So I'm sure you all do a great job on bonding your attachments to the teeth. Okay. If you're having regular, bond failures, or if when you're taking out the template, it's not bonding the teeth, come back to these instructions and see what you can do to improve your bonding technique there. But what we want to stress is you want really well shaped, really well defined attachments on the teeth that are flush to the tooth without excess material. So you can see here, this to me looks like there was excess packable composite that was placed into the template, and then it was smashed onto the tooth. But you can see here, this whole area, I can't draw very well with a mouse, but the whole area where you can see this big patty of composite, that whole area is not going to have good contact between the aligner and the tooth because it's not supposed to be there. And so this area is going to hold the rest of the aligner away from the actual surface of the tooth. And so the whole entire surface of the tooth is not going to be getting good contact from the aligner. So make sure that you don't have all this extra composite material. Okay, you want attachments that are really clean and right on the tooth without all this extra composite. Okay, so even though I do slightly overfill, I do it with flowable composite, and I do it in a way that thins it out, whisper thin, so it's barely there. Okay. So let's talk for just a second about wear schedules, because everybody has the question of, should we do 1 week wear or 2 week wear? Okay, so these are Don's notes right here. He says the standard in the industry is to wear the first several trays for 2 weeks each, and realize that there's no tooth movement in the first aligner. Okay. It would be nice if there was maybe a teeny little bit of tooth movement, just kind of expanding everything out so that the body started that cellular activity. But everybody's aligner, that first one, is basically a passive aligner for the patient to wear, to get used to wearing. And even the fact that those are in there, it probably does wake up some cellular activity just having those in there. Okay, but just realize that the first one is basically passive. And then the movements start off slow. Okay, so we're going to start them off at 2 weeks per aligner. And then we're going to increase the speed as we go if the patient is showing good tracking. Okay, so standard in some companies is to wear the trays for 2 to 3 weeks. The problem with having the trays in too long is that the material of the aligner actually decays. They're not as active. They're not as the material doesn't have the same properties when it's been in the mouth longer. And so it reduces the amount of force being applied to the tooth. Okay. Experience tells us that the teeth are going to move best during the first week that the aligner is in. That's when it's most active. And so if the patient is wearing the aligner well, 22 hours a day, they can change their aligners once a week. Okay. But I'll show you in the next slide how I would work up to that. So keep in mind that there are a lot of variables. Okay. Older patients have less periodontal ligament space and a lack of osteoclast and osteoblasts needed to move the teeth through the bone. If you're doing finishing aligners and the teeth have already been moving, you already have a widened PDL, you can move the teeth a little bit faster and go a little bit faster because all of the cellular activity is already active to move the teeth. The amount of activation in each stage or each aligner determines the initial force applied and when the next activation may be applied. We like small activations, so smaller movements are better, even though it's more aligners and more frequent tray changes, it's more predictable and more efficient. So it says here, progressive aligners are programmed for small activations per stage, so smaller movements. So the typical tray change can be every week if the teeth are tracking well and the patient's wearing the aligners 22 hours a day. Tray change schedule depends on the patient compliance. Okay, if they're only wearing the aligners 15 hours a day or less, you're not going to get the movement out of it, and they're going to have to wear them 2 weeks or longer. So here is the protocol that I would recommend. And you can even share this with the patient. Like, hey, the recommended wear time is 1 to 2 weeks because there's variability from one patient to another. Okay. The most significant variable is the patient, is their compliance in wearing the aligners. If they're wearing the aligners 22 hours a day diligently, then you should see very good tracking, and a 1 week wear schedule is ideal. Okay. We recommend, however, that you start with a 2 week wear schedule. Make sure that everything's moving forward, that the patient's doing a good job, that the teeth have started that moving process, and then reward the patient for good behavior by speeding it up. So if the teeth are tracking well, it looks like they're wearing them diligently 22 hours a day, go to 10 days for the next couple of aligners. And if things continue to go well, they continue to see the teeth are fitting in the aligner well, then go to 1 week aligner wear, okay? The most predictable wear schedule would be just basically to ask the patient not to change the next aligner until they can visually see and feel that when they bite on those chewies, that all of the teeth fit perfectly into that aligner. There should be no little gaps between the aligner, plastic, and the tooth. So no little air bubbles, no little visible gaps between the aligner and the tooth. And when they bite on the chewy, there shouldn't be any give anywhere. It should all be fitting perfectly. And the aligner at that point would no longer feel tight. So that's the ideal time to change, whether that's 7 days or 10 days, okay? Because we have all of these variables. So in addition to the patient compliance, we have the age of the patient, okay? So younger patients' teeth will move more easily. We have the muscle strength of the patient, because strong muscled patients, brachyfacial, skeletally closed patients will have more dense bone and the teeth will move more slowly in that bone. We have clinical crown size. You know, if we have big clinical crowns, we have more surface area to apply the force, and so the teeth will move more predictably. And if there's smaller clinical crowns with less undercuts to engage, then we're going to have slower, less predictable movement. And then how complex is the case? How complex are the movements involved? How well did the stager stage those movements? Okay, and so that complexity of the movements are also going to determine how well the teeth are moving on the certain wear schedule. So if everything's going ideal, 1 week aligner changes, but I would start with 2 and work your way up to 1. We'll show you in a minute where you can find this chart right here that's in the Progressive Aligner Doctor Portal. And this chart, if you don't understand what you're looking at here, is basically showing for each different tooth. So here's all the teeth numbers. It's showing the total number of aligner stages and the blue stages. Each blue stage is an active aligner. So you can see, oh, this tooth 3-3 is not moving for the first, what is that, 6 aligners before it starts moving. There must be a reason. They must be having to move some other teeth before they can start moving this tooth. Okay, so here's your active aligner stages. And then there's little marks on here that show you where there's going to be IPR to be done, where attachments need to be put on, where an attachment needs to come off, where you need to take off an attachment and replace it with another one, where there's a virtual jump, which we'll talk about a little bit later. Okay, so this helps you understand the staging. When you get your box that has your patient aligners in them, you should get a couple of pieces of paper in there that actually show you the overview that you can pull out whenever the patient comes in. That's another way to look at what we just looked at, that says, hey, you know, this aligner stage, you're going to do this IPR. It gives you a place to check that off that you did it. It shows you what stage you need to put your attachments in. So just be aware that if this will probably show up in your box. If it's not there, you can go to, this is what it looks like, the little toolbar inside of the Progressive Aligner Doctor Portal. You can go to the overview tab and it will bring up these pages so you can print them and keep those for checking off your progress as the patient comes in. So you're keeping track of the IPR you performed to make sure that you did all the IPR that was indicated. Okay. As the patient comes in, I like to see my patient every 6 weeks. We are partnering with a company called Dental Monitoring. We're going to be introducing that later this year. If you do dental monitoring with your cases, then this whole idea will change. You'll be using AI, which we'll talk a lot more about later. You'll be using AI to tell your patient when they can move to their next aligner, because it won't let them move until all the movements have happened. It won't let them change until they get, the green check mark that they can move on to their next aligner, that all the teeth moved properly. And they don't actually have to come in until there's a problem. So if everything's tracking properly, they don't even need to come in, take the time off work or off school. But for now, until you're doing that, I have my patients come in every 6 weeks with aligners. So I give them enough aligners, depending on their wear schedule, to go 6 weeks. And then I just ask them when they come in to be wearing the tray that they're finished with, and bring the ones that I gave them that they're already finished with, in case I need to go backwards into the aligners. When they come in wearing the one that they're finished with, ask them to take it out and put it back in. If they've been wearing their trays well, they're going to be really good at that. They're going to pop it right out and then pop it right back in without any problem. If they struggle to get them out, or they've struggled to figure out how to get them back in, they're probably not wearing their aligners very well. So they're probably a sign that there's some non-compliance going on there. So they come in wearing the aligner that they think they're finished with, and we're checking it in their mouth, the one that they're finished with, to make sure that it's fitting the teeth perfectly, that it fits over all the teeth, it fits over all the attachments without any little gaps or little, areas where you can see the tooth hasn't moved yet. Because it makes no sense to move on to your next aligner and hand out new aligners to the patient if we haven't completed the movements that were previously programmed to be done. So if there's little tracking problems, we have to figure out what we need to do to get them back on track. Okay, and there's lots of tips and tricks we'll talk about as we go through these webinars to address that. The first one for me, though, is check to make sure that there's adequate space between the teeth. So yes, sometimes there's IPR indicated where we would go and actually remove enough tooth structure to see a visible gap between the teeth. But separate from that, it's a very good idea in your aligner cases to use a super fine diamond single side coated metal strip and go between the teeth to make sure that there's no tight contacts, to keep all of the contacts nice and loose, to keep any calculus or rough tooth surface away from those contacts so that the teeth can move against each other well. All right, that's a really good tip on getting your aligner cases to work well. So if I see a tooth that looks like it hasn't quite achieved its movement, I'm going to go in there and check to make sure there's not a tight contact, because that could be binding and keeping the teeth from moving. And so once I've verified that there's enough space there, their patient's going to have to stay in that aligner or even go back an aligner or two until we get one that's closer. And we're going to have them focus with chewies on that one area and just bite for several days until they can get the tooth to fit perfectly in that aligner and basically work it back up to the one where they were finished or into that one before we move on to new aligners. So we're looking for little tracking problems and addressing them before we just keep moving on. So educate your patient on using the chewies. Make sure that the teeth fit the aligner and that the aligner doesn't feel tight before we change to the next one. Okay, so check for those tight interproximal contacts, lighten any interproximal contacts, clean out interproximal calculus. It's kind of like oiling the teeth so that they'll move easily, okay? And then praise your patient and encourage them and show them the progress that they've made. Pull up the setup and show them, hey, you're at liner number 10, look at how much your teeth have moved. And help them keep excitement and feel good about the progress that they're making to get to the end point. Remind them that it's their job to wear the aligners and get the teeth straight. You are the advisor to help them get to that point, but really it's in their hands to get their teeth to that point. It's up to them wearing it and using the chewies to get their teeth to move into these aligners. With aligner cases, you can plan on revisions. I think that the progressive aligners, the way we do them, is probably your best shot at not having to do revisions. And the case that you're going to see today was done in the first set of aligners. There were no revisions done. But for me, most of the time, I'm going to plan on at least one revision or refinement. Okay, a revision is where we're partway through the case. We're not to the end of the series of aligners, but we've lost tracking, that the aligners aren't fitting well enough and I can't do anything to get it back on track. I just need kind of a reset. I need a restart. I need a new set of aligners to fit the current condition of the teeth, the current positions perfectly, and continue to move them to the endpoint from there. So that's a revision. A refinement would be, I've gotten to the end of the aligner set and there's just some finishing to do. I didn't get everything perfect from that first set. I just would like to continue to fine tune things. Okay, but whether it's a revision or refinement, when you go into your doctor portal, under the patient, you'll find this button that says refinement. And if you've chosen an unlimited case, you have an unlimited number of refinements or revisions. When you click that button, it will initiate that process of requesting, a new set of aligners, basically. If you did a product that's 20 or 30 aligners, then it's going to limit you to 2 revisions or refinements. And it will show you how many you have left there. Okay, but our protocol, when you do these revisions or refinements, I was going to tell you, for me, it's a lot like golfing. Okay, so your first set of aligners is kind of like that swing from the fairway. to get the ball as close to the hole as you can get it. And sometimes you get really close and you just need one little putt to get it in. Sometimes you require a few more swings to get it into the hole. And then every once in a while you get a hole in one and you didn't need any revisions or refinements, but plan on revisions and refinements to make up for the inefficiencies in the aligners, which is just part of trying to straighten teeth with plastic. Okay. So the protocol is remove all the existing attachments before you take a new scan or new impressions for your revision. Okay. The old ones are going to have worn down slightly. They're not going to have nice, crisp, clean surfaces. They may have broken. They may not be needed anymore for the movements that are still necessary, or you may need a different orientation, or maybe you need one where there wasn't one. Okay, so it's a good idea to just remove all of your attachments before you take your scan or impression. I like to remove the attachments by using a fine flame diamond burr, which finds its way really easily between the enamel without cutting the enamel and the composite. So I remove most of it with just a high-speed handpiece and a fine flame diamond burr. And then any little bit that I didn't get off with the diamond burr, I use a high-speed brownie polishing point. Some doctors like to use a carbide finishing burr to remove the whole attachment. So whatever works in your hands, but take off all of the composite, smooth it up. This is also an ideal time to refine the anterior tooth anatomy if you did not do it at the beginning of the case. Okay, it's hard to get the teeth to look straight and to get a nice looking setup if you don't have symmetrical teeth with nice anatomy. So if you didn't do it at the beginning of the case, when it's time for revision or refinement is a good time to get out a disc or a burr and smooth the incisal edges, straighten them, create some ideal anatomy, create some symmetry between the teeth on the right and the left, because before, when the teeth weren't straight, they've worn unevenly. You'll have a lot of wear on one side or one part of a tooth and not on another. You'll have one canine that's worn down and one that isn't. Okay, so it's a nice time to kind of idealize that anatomy. And you could consider taking a new lateral ceph at that time and even, re-diagnosing the case and seeing what you need to do from there if you still have a ways to go. You will need to take some new photos of the teeth to submit with your revision. So it's a nice idea to get some new photos again and get a commitment from the patient that they are willing to continue wearing the aligners for the rest of the tray. So when I'm doing a case, I don't tell a patient, hey, it's going to take 25 aligners to get your teeth straight. My first set of aligners might be 25, but I don't want them focused in on that number to where they think, oh, when I get to number 25, I should be done. Okay, because more often than not, there's still going to be some more revision or refinement aligners to do. So I tell them, I think your aligner treatment is going to take 12 to 18 months or 18 to 24 months or 9 to 12 months. Okay. I leave a nice 4 to 6 month window there. And I say, this first set of aligners we're going to be using has got 25 in it, but we're going to end up using however many aligners it takes to get your teeth straight. I think it's going to take 12 to 18 months. Okay. That way, when you get to, they're done with their 25 aligners and you need to get new aligners, they're not feeling like your treatment didn't work or you're, making up for something that didn't go well. It's just expected that it's going to take more aligners than that first set. So don't let them get focused in on that number and think they're going to be done with that. And that way it's easier to get commitment to keep on going because you told them up front that you're going to probably keep going after this first set of aligners. Okay. When you do have a revision or refinement, it is a good idea to take all of the composite off the teeth rather than the option that's available, which is have the technician virtually remove the composite and put on new attachments. Okay. And you can see, if you look closely, you can see that when the technician removes the attachments, there's composite on the teeth. If you can see in these photos here, there's virtual composite still left on the teeth, because if the technician were to completely remove all of it, there would be errors and you'd have fit issues. So they basically remove all of the composite to make sure that the aligners are still going to fit. Well, that translates into when I put a new engager on that tooth, or actually, no, it works better when you put a new engager on that tooth. But if I don't put an engager on that tooth, I'm going to have a whole area that doesn't have intimate contact with the tooth. Okay. If you are replacing it, if they do remove it in one area and replace it, that ends up being a better solution. But it's just better to remove all of the attachments. So this is what it looks like when you take a scan or an impression with existing attachments, and the technician would go in there and virtually remove this attachment. It's not going to be a complete removal. There's always going to be some virtually left on the tooth, which doesn't give you perfect fit of the aligners to the tooth. Okay. So if the technician is going to remove it and put a new engager there, it won't be as bad, but it's better just to always remove all of your engagers when you do a revision or refinement. When is a case finished? Okay. A case is finished when any one of these 5 things is happening, and we'll go through those real quick, but we're trying to design a system that creates 5s, this category down here. Okay. So the first one is the case is finished because the patient is tired of the process and they want to be done. And the teeth look straight enough to them. You can tell that they're not perfectly straight, but the patient's happy and they're wanting to be done. So that's the lowest level of quality finish. The next level would be the patient is satisfied. They're happy. Okay. They see straight looking teeth. You can see that they're not, but they can see straight looking teeth. And this is the level that some mini orthodontists go for by this criteria, kind of finishing as quickly as possible without putting a lot of effort in. Just get to the point where the patient's done and they're happy. Okay. The next level would be getting to the point where your staff is happy. It's important that your staff feels that you're doing a good job, that you're treating cases well, or they'll lose interest and confidence in you. The next level would be that you are satisfied, that it's the best finish given the characteristics and limitations for that patient. It gives you a good feeling, but lack of total excitement. And the Don McGann finish, and the one that we all strive for, is I can't see anything left to improve. It's basically perfect. And when you get these kind of finishes, that feeling, that excitement drives you to want to do it again and again, and you develop a real passion for ortho. And when other doctors see your finish, they're very impressed, because it takes a lot of commitment to get to the point where there's nothing left to be done. It is perfect. Okay. And you can get to that point if you're willing and your patient is willing. When you get to the end of the case, you're going to go into the doctor portal and you're going to order a retainer. So we want you to understand that with the company that we partnered with, when you order a retainer on a 10, 20, 30 package, that ordering of the retainer indicates the end of the case. The case is closed. You won't be able to get more aligners after that. Okay. It's one reason why you might want to consider going with the unlimited package, because even if you order the retainer, if during the 5 years there's any relapse, there's any reason why you would want to get more aligners and continue treatment, the case can be reopened. You can continue to get aligners unlimited for 5 years during that warranty period. It doesn't end the case when you order that retainer. So that's a nice benefit to having the unlimited. But when you get to the end of the case, you're going to remove all of the attachments from the teeth, clean the teeth up, do any fine tuning to the anatomy that you need to do with a burr or a soft flex disc. You're going to go through and check their bite, okay, and try to do some occlusal adjustments. Remember, the teeth haven't worn into this position. You know, patients take years wearing their teeth into a nice balanced occlusion. And so we've accomplished this new position. The patient's been wearing aligners. They haven't had a chance to settle their bite in. So when you go through and check their bite, you might see that there's 1 or 2 cusps hitting harder than everything else, or a marginal ridge, or sometimes it's the lingual side of an upper anterior tooth where it didn't wear the same, like the mesial side didn't wear as much as the distal side. And so going through and just getting rid of premature contacts and try to create a nice balanced, even occlusion, and doing that as you help them through their retention. So at a 1 month recall check, a 3 month, a 6 month, you're constantly checking the bite in retention to make sure that they're developing a nice balanced occlusion with balanced heavy contacts on the posterior teeth in maximum intercuspation, and very light contacts on the front teeth without fremitus on those front teeth. And at the end, you're going to get a new scan, study models, photos to keep as your finishing record, so that you have records of how you finish the case. So in this case that we're going to look at today, you're going to see a blocked out cuspid. So let's talk a little bit for just a minute about protocols with progressive aligners for blocked out canines. First of all, would be looking for undercuts that would prevent the trays from seating. So path of insertion. Okay, if you have this tooth, there's going to be an undercut up at the gum line based upon the path of insertion of the rest of the teeth. So you may not want to initially put an attachment on that tooth that's going to create even more of an undercut there. Okay, it might be a good idea to keep that attachment off that tooth or put it on at a later stage in order to not create worse of an undercut. And if you're having a problem with path of insertion initially, you might have to trim away a little bit of the aligner that goes into that undercut so that for the first few aligners, they can get it on and off. You may need to see it to where you put the aligner first onto the undercut area and then basically, rock the rest of it on. So it can take a little bit of an effort to get the aligners on when you have these blocked out canines. You're going to be not only pushing this tooth to the lingual, but there's going to be an extrusion as well as that tooth comes in. So that tooth is going to need space on either side of the tooth for these movements to happen. So make sure in the setup that you can see that the technician is creating visible space on either side of this tooth before they start bringing it in so that it actually moves predictably. And they're going to want, at some point when the extrusion is done, they're going to want a horizontal attachment to give a surface area to help push on this tooth for extrusion. Okay. There is relative extrusion that happens as this tooth is being pushed lingually, but sometimes there's actual bodily extrusion that needs to happen as well. And so that requires a horizontal attachment. And then we want to look at the case before we start and say, why is this tooth blocked out? Is there an asymmetrical molar position? Could it be that the molars on this side have drifted? Maybe they lost a primary tooth early, a primary molar, and the posterior teeth on this side erupted more mesially, and that's why this tooth is blocked out. Or maybe the front teeth have shifted off because of the loss of a tooth that was early, and that's why the tooth's blocked out. So we're going to want to figure out if there's asymmetry in the case so that we know how to treat it to end up with the best result. We'll look at that in this case. Keep in mind that extrusion of the upper cuspid gives labial root torque. So what that means is when I bring this tooth down, that's pushing the crown lingually, which is going to tend to want to push the root out to the buccal. It's going to want to tend to push the root to the labial. So we're going to want to counterbalance that by applying lingual root torque in the setup, or essentially as we bring this tooth down, we're going to want to see that the technician has applied some lingual root torque. They've either retained that torque position as they brought the tooth down, or they've even added some lingual root torque. They've moved the root to the lingual to counterbalance the fact that normally the root wants to swing out to the buccal when this crown is brought down and in. Okay, we'll look at that in this setup. And then we're going to talk a little bit about open bite in this case. This is not a severe open bite case. In fact, we'll see in a minute that this case actually had very light contacts on the anterior teeth. There was no overbite, but there wasn't a straight open bite in the front. So some of these things that we'll talk about are not going to be applied to this case, but we will discuss it at the very end. Is this case also skeletal open bite? Okay, so if we have a dental open bite, we want to look at the lateral ceph and trace it and evaluate whether or not there's skeletal open bite. Is this a dolichofacial patient? Do they have weak muscles? Okay, if they're skeletal open, they may not have enough muscle strength to be able to intrude their back teeth with the aligners to help close the bite. Okay, so severe open bite cases, especially ones that also are skeletal open, they might require extractions to help close the bite or even surgery. Okay, but in general, aligners are very good appliances for closing mild to moderate open bite, especially if the patient has moderate to strong muscle strength in their jaw. Okay, so an open bite is defined by less than 1 millimeter of overbite. Okay, so if we have less than 1 millimeter of overbite, that defines the open bite, which is what we have in this case, even though there are some light contacts on the anterior teeth. Often we're going to be extruding the anterior teeth in order to close the open bite, and that's going to require attachments, horizontal attachments, so the aligner has something to push on, like I drew a minute ago. And if there are bevels on the attachments, it may be more effective to have those bevels facing the gingival so that we have more surface area on the bevels facing the occlusal or the incisal so that we have more surface area on the gingival surface to push on. Okay, and we have to have space available for the extrusion. We do want to look at patients though and look at how much gummy smile they have and how much incisor display they have when their lip is at rest, because if they're already too gummy or they have too much, if they're showing their whole incisor with their lip at rest, we may not want to extrude their anterior teeth to close an open bite because that would make the gummy smile worse. And so I'll show you at the end of this seminar, this webinar, some setups in cases where we don't want to extrude the anterior teeth as much as possible. Okay, so in some of those cases, we'll be really focusing on intruding the posterior teeth to get the bite to close rather than extruding the anterior teeth. But in a lot of cases, we'll be both intruding the posterior teeth and extruding the anterior teeth to close the open bite. And you'll see more that will be demonstrated better later in some other slides. We want to look at what habits may be there, because if there's an open bite, there's actually no contacts in the front, then something is there to cause that. There's either a tongue present or a thumb or some habit that's preventing the teeth from erupting into occlusion. The nice thing about aligners is if they have a tongue thrust, that tongue thrust is kind of removed from the equation while you're wearing aligners, which is why one of the reasons why I think aligners work well to close bites. If you have braces on and the patient continues to tongue thrust when they swallow, the tongue is continuing to apply forces to the teeth despite the fact that the braces are present. With aligners, because the movements are happening inside of this plastic, the teeth are kind of protected by the overall appliance from the forces of the tongue. So as the patient tongue thrusts, they're not able to put pressure on individual teeth and continue to push those up. Everything that's happening, if they tongue thrust, the whole aligner is feeling it and it's not going onto those individual teeth. And they actually tend to just function differently when they have those aligners in place. So, but be aware of a tongue thrust. Often we'll want to refer the patient to a myofunctional therapist. That always helps to have them learn how to use their tongue and their mouth properly for swallowing and breathing and eating in order to help us get that bite closed. Okay, looking to see if there's interferences from the posterior teeth. So if there's third molars present and when the patient bites, that's their strongest contact, we might want to extract their eighths so that they can get their bite to close more. If there's plunging cusps on the sevens or the sixes, and so we have a low hanging cusp that's hitting first, we may want to take a burr and adjust those down so that the bite can close more by just getting rid of those premature contacts. And I'll have a slide later where we show as well that sometimes there's a transverse deficiency. And so if they have maybe not a true crossbite, but it's almost like the buccal cusps of the upper are hitting the buccal cusps of the lower, that's going to also keep the bite open in the front. So some expansion in the upper will also help the teeth interdigitate better in a transverse dimension so that the bite can close. Okay. The endpoints, the target points of our setup should be overcorrected. In this case, there was no overcorrection done, we'll see. And the case worked out really well. And we'll talk about that a little bit as we look at it. But just be aware of some of these points as we go into looking at this case. Another thing that we want to consider is whenever there's dental class 2 with aligners, often we'll find that there's some mesial rotation of upper first molars compared to the rest of the teeth in the arch. Okay. I've drawn that a little bit severe, but so if you look at the overall arch form, you'll see that there's a little bit of a mesial rotation of the upper first molar compared to the rest of the teeth. And so if we ask the technicians, which the progressive aligner technicians should do for you, but just be aware of it, if we rotate this tooth around the palatal cusp so that the mesial comes out and the distal goes in, that actually helps to fix the class 2. this tooth is taking up more space in the arch with this rotation than it would if we derotated it. Now, when we do brackets and we put the bracket on and we align with a wire, that naturally happens. But if we're not aware of it and we don't point it out and make sure that the technician applied that movement, then we might miss an opportunity to correct a millimeter or two of class 2 just by rotating that upper first molar to the distal. Okay, so with an aligner, you can go and look at the setup from the lingual view. And if you can see from the lingual view that the mesial palatal cusp fits right into the central fossa of the lower first molar, and the distal palatal cusp is making contact with the mesial marginal ridge of the second molar, then you basically have a class 1 molar relationship on the lingual side. It's just not class 1 on the buccal side. And so that rotation is going to move this distal buccal cusp and the mesial buccal cusp into a more class 1 position. So keep an eye out for that in your cases. And then the last thing I want to point out before we start looking at this case is the Bolton discrepancies, Bolton analysis. Okay, to actually do a Bolton analysis without using computers and software, clinically, you would have to go and use calipers to measure each one of these teeth and then add up all of the measurements and put it into a formula, basically ideal for the teeth to fit together and coordinate properly. The tooth mass in the lower, if we're just looking at the anterior teeth from 3 to 3, the tooth mass in the lower should be 77% of the upper, plus or minus 1.65. If that's the ratio, then the teeth should fit together right and should coordinate properly. If it's not right, then you either have too much tooth mass in the upper or too much tooth mass in the lower. And the nice thing about technology is we can go into the setup in the Progressive Aligners portal and click on this measurement tool. And that will bring up this option for the Bolton measurement, and it gives you this Bolton analysis, okay? It tells you the width of all of your teeth, and it says, in your case, your upper arch is 1.28 millimeters bigger than ideal if we're just looking at the anterior 3 to 3. But if we look at the whole arch from 6 to 6, you actually are 2.15 millimeters bigger. Why is that important? Well, that tells us that if this were the case, that when I have class 1 in the posterior occlusion, the extra tooth mass in the upper is going to create excess overjet in the front. And so to get class 1 occlusion and ideal anterior overjet, I'm going to have to take away some tooth mass in the upper. So I'm going to expect to do some IPR or some tooth reduction, maybe up to 1.28 millimeters in this anterior section from 3 to 3, and maybe even a little bit more in the posterior. So, you know, an additional, what is that? Maybe an additional 0.8 millimeters, something like that, in the posterior teeth in order to get ideal coordination of my upper and lower teeth. If there was more in the lower arch than the upper, then I might have to do IPR on the lower arch to get it to coordinate with the upper. So this Bolton analysis is done for you by the computer, and it cues you in to the fact that you have bigger teeth in the upper or bigger teeth in the lower, and that could be why IPR is needed to get your teeth to coordinate well. So let's actually look at this case. Thank you for hanging in there with me through that hour and 20 minutes of prep work. But this is the fun part. Let's look at this case. All right. This case was provided for us courtesy of Dr. Lucy Galletley from Queensland, Australia. I'll introduce her in just a minute, but I want to recognize that the consulting and mentoring for Lucy was provided by Dr. Amit Lala and Dr. Don McGann. And so we're grateful to all of them for providing us with this education. This is Lucy. She has a practice in Queensland, Australia. I had the privilege of meeting Lucy when I was teaching an aligner course in, gosh, I don't remember if we were in Melbourne or in Sydney for this particular course, but I got to meet her, and she was just starting ortho in her practice and getting involved with ClearCorrect at the time. This was in 2019 when she completed her Aligner Plus series and used Don McGann as a mentor for all of her cases, 32 as of November 2022 when he put this together. All aligner cases, she doesn't do any brackets at this point. She refers out any cases that require brackets. She had some experience from some ClearCorrect cases before starting with Dawn. Okay, but I think this is her first case with these aligners. So we're grateful to Lucy for providing us with these photos and the opportunity to present this case to you guys. Thank you, Lucy. So here's our patient, 17-year-old, presents to your office. Chief complaint is crowding, okay? And the obvious one being her canine that we've talked about that's blocked out, and that's probably her chief complaint and reason to come in and have you look at her teeth. It's kind of sticking out there. Okay, so the first thing I do whenever I look at a patient is I want to look at the facial balance, because I want to, before I ever look at the teeth and really consider how I'm going to fix the teeth, I want to look at the facial balance and decide, am I happy with the facial balance? Is the patient happy with the facial balance? Am I going to want to see the lips move forward or come back or stay the same? Okay, so looking at her profile, if I look at the aesthetic plane, I can't draw a straight line, but if I could draw a straight line from her nose to her chin, her teeth are behind that plane. And so in that regard, you would say she's slightly concave. All right. Looking at her overall face, again, I can't draw very straight, but looking at her overall face, she's fairly straight. So what do you call this patient? Straight profile or concave profile or straight to slightly concave? The question I would ask all of you is, looking at this patient, do you want to move her lips forward and give her more lip support? Or do you want to move her teeth back and bring her lips back because they're too protrusive? Or do you like her facial balance and want to leave her basically where she is? Because the answer to that question is going to determine how I set up the case. Am I going to want to allow the teeth to come forward and give her more lip support? Or do I want to make sure to bring the teeth back and reduce protrusion? And I think we could all agree that she looks acceptable. If I could finish with her looking the way she is, I think she'd be happy and I'd be happy. Because she's straight to slightly concave, I wouldn't personally want to see her teeth being retracted, bringing her teeth back and allowing less lip support. So I either want to leave them where they are or allow them to come slightly forward and give her slightly more lip support. Okay, her nasolabial angle is pretty close to 90 degrees. So that's within normal range. Her sublabial fold is pretty average. She doesn't appear to have protrusion of her lips. So I would just say, whatever I find in her mouth, however much crowding there is, whatever needs to be done, I'm going to lock into my mind that I don't want to move her teeth back. I want them to stay where they started or go slightly forward. Okay. She looks to be mesofacial, so average muscle strength. When I look at her smile, it's hard to see in this photo. We'll see it in a minute, but if you can see her midline, it looks like her upper midline is off a little bit to her right side. Okay. And she has kind of a little bit larger black triangles, these black corridors in the cheek here, the buccal corridors. If we have a lot of crowding, it wouldn't be a bad idea to do some expansion with the aligners to fill those buccal corridors out a little bit. But if I'm going to do an expansion, I want to make sure that I'm not retracting her teeth and making her look worse because I've lost lip support. Okay. So we're looking a little bit closer at the teeth, and this is what we see. Okay. What are some of the things that jump out to me when I look at this? Well, the first one is this overlap of her upper incisors. So on all of my patients, whenever I see incisors overlapping like this, I warn them that when we straighten the teeth, we could end up with a black triangle up at the gum line. Okay, so just warn them of that you might have that develop and that you might have to do some IPR at the end of the case to bring those teeth closer together in order to avoid a black triangle from this situation. And I might want to apply, if I look at where the roots are going, I might want to apply some mesial root tipping to try to keep this contact nice and tight so I don't open up a black triangle in there. Okay. I see that we don't have any overbite. It's less than 1 millimeter, but it does look like we have some slight contacts. It doesn't look like she has a tongue thrust habit where she has kept her teeth from actually having contacts in the front, but she doesn't have very much overbite. Her midlines don't line up. Okay, so here's the upper dental midline, and here's the lower dental midline. And it should be a red flag. We're going to want to identify where that is coming from. And it may even be a reason for you that if you don't understand the case, to have a consultant or mentor, and it may be a case that you end up not treating. Okay, but in this case, it was diagnosed and treatment planned very well and treated very well. But the question is, what's off? Is the upper midline off? So where's the facial midline? Is the facial midline in line with her upper? And it's actually her lower that's off, maybe because her mandible is shifted over to her left side, or maybe all the teeth in the lower are shifted around to the left side. That could be one possibility, or two possibilities, dental asymmetry in that lower arch or functional shift of the lower arch. But what if the facial midline lines up with the lower and it's the upper that's off? Well, then we probably have asymmetry in the upper arch. Probably all of the teeth in the upper are shifted over. And maybe it's because we have this blocked out canine that everything is shifted over to that side. It could be that the maxilla itself is skewed or rotated inside of her mouth. We need to look at whether the molars are in a symmetrical position or not. Like, is it all of the teeth that are off, or is it just the front teeth? Okay, so we have to be investigative and figure out why these don't line up so that we know how to treat the case. Okay. From these pictures, it looks like we have nice, healthy gum tissue. I don't see a problem with advancing the incisors if we need to a little bit. It looks like we have more crowded in the upper than the lower. And it's hard to see in this photo. We'll see it better in the models in just a minute, but she has a little bit of canine class 2 on the right side. In this photo, if anything, that canine looks like it's a little bit class 3, but we'll see in the actual photos that of the models, when we look at the correct angle, that there's a little bit of class 2 on the right side. The lateral ceph shows us that there is some areas where the teeth, are open in the front, and there is a little bit of an open bite or an open bite tendency there. Okay, we definitely don't have overbite. So drawing a line through the center of her face shows us that her upper midline actually is off to her right side. And when we do the model tracing, it looks like the posterior teeth are pretty symmetrical. There's a possibility that this one on the right side is maybe on her right side is a little bit forward, and that could be contributing to this blocked out canine. But the model measuring looks like they're fairly symmetrical. So what that means is if we were to procline these front teeth to allow them to straighten, and we bring this canine in, that's going to shift her midline to her left side, which is the direction that it needs to go. Okay, so it could be that her lower, with the crowding, her lower maybe is off just a little bit to her left side, and it would be okay to shift that just a little bit, maybe 0.5 millimeter to her right, and that the upper really is what we want to see shift. So in her case, because we can visibly see that her upper midline does not line up with her face, we're going to want to see her upper midline shift as we bring this tooth in. Could she have a functional shift of the mandible? Could she be shifting her mandible this direction? Well, we would normally expect to see a bigger difference between the amount of class 2 on the right versus the left, something more like 3 to 4 millimeter difference one side versus the other. And in this case, it's only about 2. We'll see that on the next slide. And also, we would normally look at the overjet and the posterior teeth at the canines and see, like, hey, is it more on the right side because she's shifting her mandible off to the left? And you can't really use that as a guide in this case because her canine is flared out. So it makes it look like there's more overjet here and that she's shifting to her left, but that's really not reliable in this case because of her flared canine. We can look at her face and say, well, her chin looks pretty well centered with the facial midline, so maybe she's not shifting that mandible over to her left side. Trying to look at the panoramic x-ray and look at the I'm blanking on the word right now, the fissure or whatever between the bones there, does that line up with the contact? And maybe it is off a little bit to the right side based on this. So there's some questions remaining about what needs to change, but looking at her face, she would look better if her upper teeth moved to her left side. So I'm going to want to convey that to the technician, that I want her lower to maybe shift just a little bit to her right, but I want the upper midline to shift more to her left. Okay, we can also look at photos. We can look at the palatal raphe and see, hey, if I project that line forward, where am I hitting? Is the midline off? Okay, so there's lots of tools we can use to try to visualize where this needs to go. But this is one of the reasons why we have to get good photos of our face. Like if your patient photo has the head turned slightly to the right or the left, it's very difficult to evaluate where that midline is relative to the face, because ultimately that's what we want, is we want the upper midline to line up with the face. So it's very important to get a good photo of the patient from the front, where you can see the same amount of the ear on each side, so they're not rotated left or right. Okay, and maybe get another photo with the patient with their lips at rest, so that you can look at the Cupid's bow of the upper lip and see where the upper dental midline falls relative to Cupid's bow. But we want to communicate with the technician what needs to move in order to get these midlines corrected. So here are the models. This is from a CEREC scan viewed in MetaLink software, which is a free software that anybody can use. And you can use any STL file from any aligner or from any scanner to view. And again, we see that the midlines are off. And now we can better see that on the right side, we have some class 2. Okay, because this cusp tip right here should be right there. So that looks like about 2 to 3 millimeters of class 2 on the right side. Same thing with this bicuspid. Same thing with this molar. There's a gap right there. And same thing with this canine, should be down here. So we've definitely got a couple millimeters of class 2 on the patient's right side. And over on the left side, we're closer to class 1, but even on the left side, it's not a perfect class 1. We still have maybe a millimeter of class 1 on the left side. Okay, so there definitely is some class 2 dentally in this case. And we can see that in the lower arch, we have maybe a millimeter, 2 millimeters of crowding, not much. It's a pretty good lower arch. So we're definitely not going to be extracting this patient. And in the upper, a quick count of crowding is going from the mesial of the first molar to the mesial of the first molar and counting broken contacts. Okay, so the obvious broken contacts here would be 1, 2, 3, and then there's some minor ones. So I'd probably say there's 4 millimeters of crowding. You might even say 5 millimeters of crowding, but there's somewhere between 4 and 5 millimeters of crowding in the upper arch. So we have more crowding in the upper than the lower. So we would expect that when this patient gets a teeth straightened, we're going to see an overjet problem, unless we deal with the class 2 and either move the upper teeth back or move the lower teeth forward. And also remember, we had that Bolton discrepancy with this patient. She has more tooth mass in the upper than the lower. So that's another reason why we would see the uppers advance more. Okay. Here from the lingual view, we can see that these molars look pretty good from the lingual side as far as being a class 1. So she's not far from class 1. Definitely rotating those upper molars to the distal will help get her into class 1, and maybe a little bit of actual distalization on the right side. We're going to want to level these arches. Okay. And so with our brackets, typically when we had a curve of Spee, which she doesn't have much of a curve of Spee in her lower arch, but typically we level the curve of Spee with brackets because the bicuspids are extruded and the 6 are extruded to the level of the occlusal plane as determined by the incisal edges of the lower anterior teeth and the cusp tips of the 7s or the second molars. And then the brackets and the wire extrude the posterior teeth in between those 2 points, which is why braces tend to open dental bites. But with aligners, it's difficult to extrude teeth. It's not a movement that works easily because aligners need to push on a tooth surface. And there's really no tooth surface to push on to extrude a tooth. It can't push on the apex. And so even if we put an engager, it's still a very small surface area to try to exert a pushing force to get this entire tooth to extrude. Okay, so extrusion is not a real predictable movement. Maybe on a younger teenage patient who actually still has some eruption potential, but on an adult patient, it's going to be very hard to get extrusion of these teeth. So we tend to level the curve of Spee and the occlusal plane with intrusion of the posterior teeth and intrusion of the anterior teeth to the level of the 6 and the 4. Okay, so in our new software that's going to come out later this year, early next year, the simulations that Don's been working on with Medit, which you guys are going to love hearing about, he set up the occlusal table as being a straight line from the distal buccal cusp of the first molar to the buccal cusp of the first bicuspid, from the 6 to the 4. And then if we look at the occlusal table of the upper arch, often we see the upper incisors are erupted beyond that level. In her case, they're actually slightly above the occlusal plane. And so in her case, it would be appropriate to do some extrusion of her upper incisors to close that open bite and create some overbite for her. Okay, but in our aligner setup, we're going to want to see leveling of the arches and alignment of the teeth. So as you all know, in SmileStream, we're going to work up our cases just like we do for brackets. Okay, we're going to trace the lateral ceph. We're going to get a ceph analysis. We're going to trace the models. The traced lateral ceph plus the traced models give us a 2-dimensional VTO and predicts, like we thought, that the upper incisor is going to advance more than the lower incisor. And that would make sense given that there is dental class 2 and she has extra tooth mass in the upper. So to get her overjet proper, either the lowers are going to have to come forward more or the uppers are going to have to go back, or both. Okay. Interestingly, she's a little bit mild skeletal class 3, given a width of -3. And my eyes are going, so these numbers are small for me, but an A and B measurement of about 0.9, almost 1. So she's a little mild skeletal class 3 with some mild dental class 2. She's skeletal average, so she has average muscle strength, and the teeth should move well if she wears her aligners well. Okay, Don used a non-extraction tapered wire in his tracing to come up with this VTO to fit the arch form, to maintain that arch form. If we do a VTO with expansion, so using a different wire, using the non-extract ovoid number 1 wire, which you can see would represent target positions, endpoints that are more expanded through the bicuspids, and you can also see how that would rotate the upper 6 to the distal, mesial out. It's going to expand those bicuspids out. Okay, if we use an expanded wire, or with our aligner, we use an expanded arch form. So we expect to see some rounding out of the arch, not by expanding the 7s necessarily, but by rotating the 6s and then pushing the bicuspids out to the buccal and rotating where needed, like this bicuspid here needs to be rotated. Then we don't get as much advancement of the upper teeth. Okay. And so we'll do some expansion of the upper, and it's not uncommon in these dental open bite cases to have a little bit of a deficient transverse in the upper. Hers was actually pretty okay, but we usually do some expanding of the upper. Just keep in mind that when we expand the upper teeth with an aligner, picture that we're pushing on the lingual surface of these teeth. And when we push on the lingual surface, they're going to have a tendency to tip. The crowns are going to want to tip to the buccal. Okay. They're not going to want to move bodily. They're going to want to just tip the crowns to the buccal. And if they tip to the buccal, not only are they going to look flared, but the buccal cusps are going to go up and the lingual cusps are going to come down as they flare or tip to the buccal. Lingual cusps coming down is not good for an open bite case, because the more they come down, the more the bite's going to open in the front. So we want to be careful as we apply expansion, and we're going to want to ask the technicians to apply extra force on the roots. Okay, so the way that, obviously the aligner is not pushing on the roots, but the aligners are going to be set up in such a way that basically it's pushing harder down at the gingival level on the lingual side than it is on the cusp tip. Okay, so that it's basically trying to push the root more to the buccal than it's pushing the crown. So as these teeth expand, we want to see the crowns kind of tipping to the lingual as they move to the buccal bodily, and it's going to look like the roots are moving more to the labial than the actual crown is. And that's just to overcome that flexibility of the aligner and the tendency of the teeth to tip buccally by pushing harder on the roots, you know, basically pushing hard at the gum line to try to get those roots to go out to the buccal. That's a case where maybe if you're having a problem with it, you could request in a revision aligner, you could request straight trim line that's up higher on the gum line, which would have more impact and more effect on the gingival portion of that tooth to control that torque. And we'll see that in the setup in a minute. You'll see the torque being applied to those posterior teeth as they expand. So the treatment decision was to use some expansion to limit the advancement, maintain her profile, and give her a little bit of a more full smile and fill those buccal corridors out a little bit. So keep in mind that she has this Bolton tooth discrepancy. She's 1.2 millimeters larger in the upper 3 to 3 and 2.15 in the upper 6 to 6. So it would be appropriate to do some IPR in her upper arch to reduce the resulting overjet. So here Dawn's reminding us that it's a really good idea before we submit the case to start to get rid of any irregularities from the way the teeth have worn. Okay, so I like to pick up a, if I know the patient's going to do aligners, before I take the PVS impression or scan the teeth, I pick up a soft flex and I just create a nice straight incisal edge that's perpendicular to the long axis of the tooth. Okay, so each tooth is going to get a straight incisal edge that's perpendicular to the long axis of the tooth. And if needed, I try to fine tune that mesial incisal or distal incisal corner line angle. She's not real bad, but just create nice, even incisal edges. Look at the cusp. If you have one cuspid that's worn flat and one that's real sharp that's never been worn, you might want to get rid of the sharp part on the unworn cusp, so that as the technician is setting this up, all the teeth are symmetrical, right versus left. You know, I mean, sometimes you see a case where this tooth that's more in occlusion, the one that's further back, has been worn down badly. And when it gets lined up, it's going to be this long. And the one that's out of occlusion, that's more, you know, overlap to the buccal, hasn't had anywhere. And when you line these two teeth up, you're going to have different length central incisors. And then you have to make a decision like, hey, what's more important in this case? Is the gingival architecture what I'm going for? So I want the technician to create the same level gingival zenith. And I'm going to have incisors at the end where one is longer than the other. And I'm going to bond the one that's short, or I'm going to put a veneer on it. Or do I want to bring the incisal edges down to the same level and end up with a gingival zenith here and a gingival zenith here? Because maybe this patient doesn't smile very high and you don't even see the gingival architecture when they smile. And we want to avoid a restoration. So if the teeth are real badly worn, you have to make some cosmetic decisions, or maybe discuss with the patient that, you know, I'm going to give you an ortho fee that also includes my fee for putting on a veneer at the end of the case, because this tooth is going to need to be veneered. Okay. But before you start a case is the ideal time to refine the tooth anatomy so that you get nice looking teeth as they become aligned. And then whenever you do a revision or refinement, go back and revisit that anatomy and kind of fine tune it as you get the teeth straight. Some things that weren't obvious before will become obvious as the teeth become straight. Okay, but don't leave all of that refining of the tooth anatomy to the very end of the case, because it doesn't look good and it's hard for the technician to set it up for you in a way that that things just fit right and look right. All right. Don always provides an exit strategy in his consultations for his clients, which is a very good idea. What if this patient does not wear the aligners? Are you going to refer him to an orthodontist if you don't do brackets? Or are you going to be willing to put the brackets on upper and lower 5 to 5 to finish up the alignment of the front teeth so that they at least have straight teeth? What if that front tooth isn't rotating well and you just can't get that front tooth straight? Are you going to be willing to put some brackets on and help that tooth get straight? So if we're having a hard time with the aligners, it's a good idea to have a backup plan, have the patient understand that brackets may be required to finish their case. If they're not wearing their aligners well, or if the teeth aren't responding well to the aligners. And so Don has, for all of his cases, already diagnosed the incisor bracket torque that he wants. So LA brackets in the upper, LI brackets in the lower. So that's labial root torque brackets in the upper and lingual root torque brackets in the lower. He's done the range of bracket torque template and come up with positioning for the brackets, okay, so that this Dr. Galletly had an exit strategy if the aligners weren't working. He provided a suggested consultation, okay, to help them set up ideal expectations. You know, I have a 14 to 18 month plan. Notice it's not a number of aligners, it's a span of time. It's 14 to 18 months. However many aligners that takes, this is my estimated treatment time. Using progressive aligners, we're going to widen your smile, fix your bite. It's possible I'll need to place brackets on your teeth. We're going to give you a beautiful smile. We're going to reshape your teeth a little bit. Here's my fee. It includes 18 months of aligners. You know, there may be extra costs if you want to charge extra for reshaping the front teeth or doing a restoration. If you're going to charge extra for doing occlusal adjustments afterwards, you know, whatever it is in your practice, if you're going to, some patients assume that you're going to not charge to clean their teeth or take x-rays to check for cavities during treatment. So, you know, I charge for regular dental x-rays and checkups and cleanings during ortho treatment. So, you know, get rid of all of the possible misunderstandings with your consent form and your contract. So in SmileStream, you can print a contract and customize it for this case. And then on the Progressive Aligners website, you'll be able to download a consent form for using Progressive Aligners. So all of that was provided to Dr. Lucy. And then he provided her with submission instructions, which Don, hats off for these amazing submission instructions. They're probably more detailed than anybody else would have written. But Don is very precise and very observant and outlined everything that needed to happen for this technician. Okay. You don't need to go into this much detail with the designers and stagers that we're now working with progressive aligners. But when we were working with other aligner companies, we literally had to spell out every single thing and then respell it out because usually they didn't even know what we're talking about and didn't follow what we told them to do. So I'm going to go briefly through his submission instructions. Okay. Not limiting the number of stages, just saying, hey, unlimited movements for staging, however many aligners it takes, okay? So his instructions were level and expand the arches, okay? We already said we wanted to level and we wanted to expand. Procline the upper and lower incisors, creating space for the upper right cuspid, the one that's blocked out, to extrude and other teeth to rotate. So basically what he's saying is whenever we procline teeth, it's the easiest movement for the aligner. Pushing the teeth from the buccal to the, from the lingual to the buccal, or proclining them, just tipping the crowns out to the buccal, is the most predictable, easy movement for the aligner to do. Because there's going to be no collisions, because as you push them outward, it creates space. So if I was pushing them inward, they'd be banging into each other, okay? But pushing from the lingual to the buccal, there should be nothing interfering with that. So as long as the patient's wearing the aligners and the teeth are not ankylosed, they should move. If you see that simple movements like tipping crowns to the buccal is not happening in your patient, they're not wearing the aligners because it is the most predictable, simple movement to do, which is why we used to call these appliances tip and strip appliances, because you could tip the teeth out really easily and then strip to create space. All right. We don't call them that anymore because we do a lot more with aligners now than just tip and strip. Okay. They're actually very useful for fixing all types of different conditions with the teeth. But it's very easy and predictable to tip the teeth out to the buccal. So the first several aligners, I just want to see the teeth getting proclined or tipped to the buccal, creating little spaces visible in the setup in order to extrude that bicuspid into the arch and rotate any tooth that needs to rotate. I don't want to see it rotating until I see little spaces between the teeth, so there's no collisions. Okay, so we spelled that out. Rotate the teeth with no collisions. He said no IPR unless there's Bolton proportions that need to be dealt with. Okay, he indicated to them to rotate the upper first molars, especially the upper 1/6 of the one on the right side. Rotate it to the distal or mesial out, mesial to the buccal, okay, which allows a little bit of distalization and fixes it to become more of a class 1. He said, please finish with 2 millimeters of overbite and ideal overjet, which is 2 millimeters. Note that the upper midline is 2 millimeters off to the patient's right. The lower midline is nearly centered, maybe 0.5 millimeters to the left. So this indicates to the technician, oh, I need to move my upper midline 2 millimeters to the left side to fix the asymmetry. And if anything, the lower is just going to get moved a little bit to the patient's right side because it's off to the left. So that's really important to indicate. And then we go into really detailed. Okay, so he says in the upper, so the upper arch, no IPR until the rotations are corrected, and only then for Bolton proportions. Okay, we don't want to apply IPR to our cases when the teeth are overlapped and the rotations aren't corrected, because you're going to remove the wrong part of the tooth. So you don't want to apply IPR until the rotations are corrected, till the true contact is aligned, so that when you do the IPR, you have access to and are able to remove the proper part of the tooth, the actual contact area. Okay. He said, expand 2 millimeters per side, simultaneous expansion right and left. We used to have to spell all of this out. The progressive aligners will do that for you. You don't have to spell that out to them, but we used to have to spell that out. So do the right and left at the same time, and then add 15 degrees of buccal root torque. So he's saying push harder on the roots as you expand so that the palatal cusps don't drop down and cause the bite to open, essentially. And we'll see that in the setup. He says, advance and procline the incisors, shifting the midline to the left to create space to bring in the 1-3. So we said that, hey, as you bring in that blocked out 1-3, the upper midline should shift over to her left side, which is what we want. He says, apply lingual root torque as you bring that 1-3 down so that at least the tooth at the end appears to match the other canine in its inclination. We don't want to allow that root to come out to the buccal when we're bringing that tooth down and in. He told me to apply mesial root tip to the upper incisors, because remember I said you're going to end up with a black triangle there. The roots were kind of tipped distally. So he's like, apply mesial root tip as we do the alignments so that we don't end up with a black triangle there. Once there's space available with contact separated, correct the rotations. And then he indicates which teeth have more severe rotations, and he asks them to overcorrect those by 2 degrees. Okay, 2 to 3 degrees is not visible to the patient, but overcorrecting gives you the best shot of actually getting the rotation corrected. And then if you actually do accomplish a slight overcorrection, it's not visible to the patient, but if you get any relapse, it's relapsing towards straight instead of having them think that now it doesn't look right again. He tells them to level the marginal ridges of the back teeth, to align the marginal ridges of the back teeth, because that's what gets all the roots lined up. And to add distal crown torque to the upper 6s. Okay, so there was a little bit of mesial tipping of the upper 6s. So distal crown tipping or distal crown torque would also help to fix that little bit of dental class 2. IPR and retraction to reduce overjet for the Bolton discrepancy. Okay, so he's saying only give me IPR if there's problems with the overjet based on the Bolton discrepancy. He requested button cutouts, which we'll see in a minute here, on the upper canines and on the lower canines, because we're going to use, actually just on the lower left canine, because we're going to use a cross elastic, which we'll show you in a second, from the upper right to the lower left to help that midline shift. And then also class 2 elastic, button cutouts on the 6s, because we're going to use some class 2 elastics. So we'll show you that in just a second. Okay, he said start attachments at aligner number 3. Now this is up to you. Okay, some of you may want to start the attachments on the very first aligner because you don't want to see the patient back in a couple of weeks to put the attachments on. And another reason to start at the beginning is because that way the patient doesn't get used to these nice smooth feeling aligners and then later have aligners with all these bumps in them. I personally feel like as long as you go with a scalloped trim line, there's enough flexibility that the patient will be able to get their aligners in and out just fine with attachments placed at stage 1 at the first aligner. If you go with a high straight trim line, I think it's a good idea to wait a couple of aligners so that the teeth are moving a little bit before you try to add the extra retention with the attachments. Okay, but I know a lot of doctors, as I talk to you, they like to just give a first aligner with no attachments, really easy, kind of let the patient get used to them, and then come in and put the attachments on at aligner number 3. So that's just up to you how your workflow goes in your practice, okay? But here they indicated start attachments at aligner number 3. And then he indicated exactly which attachments for which movements, okay? Generally, we're going to have horizontal attachments for extrusions, for torque control, and for intrusions. But when we do intrusions, the horizontal attachment doesn't go on the tooth that's intruding. It goes on the neighboring teeth that are not intruding to anchor the aligner in place on those teeth so it can exert an intrusion force on the teeth that are intruding. So we use horizontal engagers for extrusions, intrusions, torque, and sometimes for retention of the aligner if they have small clinical crowns. It allows the aligner to snap into place on patients with small clinical crowns. Vertical attachments are best for rotations and for root control. If we're tipping the root to the mesial or to the distal, then we like to have vertical attachments. So he's indicating all of those. You don't have to do that. The software and the stagers should put the correct orientation on. And they should put it on the teeth where it's indicated. He says, set up the anterior teeth so cuspid tips are at the level of the incisal edges of the central incisors, and lateral incisors are 0.5 more superior than central incisors. So he's indicating, hey, I want canines and central incisors to be lined up. And then I want my laterals to be slightly above that line, okay? That's up to you, what you prefer, what your patient prefers. You can have them all at the same level. Okay, but he's been very specific here about exactly how to set this case up. Finish with 1 millimeter of overbite and ideal overjet. Okay, in this case, maybe finish with 2 millimeters of overbite because it was a slight open bite case. So I don't feel like you need to give all of these instructions. You're going to find that the progressive aligner stagers do very good at knowing and following most of these without you having to indicate that to them. The things he said in the lower were to expand the lower to coordinate with the upper, only IPR for Bolton adjustments, which we shouldn't have any in the lower because the Bolton discrepancies in the upper, but he didn't know that yet because we hadn't submitted the case yet. And so there was no Bolton analysis to look at yet. Advance the incisors to make space for alignment of the crowding and establish overjet. There wasn't very much crowding in the lower, but we're going to align the lower crowding, whatever is not used up by expansion, with proclination or advancement of the lower incisors. Open space before correcting rotations, and then he indicated the teeth that needed to be overcorrected. And then he said, create a curve of SPE as needed to close the anterior bite. So rather than level the curve of SPE, he said, you can actually extrude my lower front teeth and create a little curve of SPE. That's exaggerated, but do that as needed to fix the open bite. And then he asked to add attachments at stage 3, just like in the upper, and indicated which teeth and which orientation. Again, They should take care of that all for you. Level the marginal ridges of the posterior teeth. Anterior incisal edge setup is level, except the cuspids are 0.5 millimeters above the level of the incisors or the plane. So I bet Don will be doing less instructions with progressive aligner cases, or is doing less, just because so much of this is built into the protocols that we've established with our stagers. Okay, so here's the attachments that were placed for this case. Remember, vertical attachments for rotation and root control. So remember, they were rotated upper incisors, but also we're applying some mesial root tipping. And so that's why we want vertical on those teeth. And any tooth that's being extruded should have a horizontal or extrusion attachment. You can see the button cutouts placed. Okay, this allows you to place a button, bond a button to that tooth, which we'll show you in just a second. Okay, so what's the deal with the buttons in this case? Okay, well, we want to use, because the midlines are off, and we're going to be trying to move the uppers to the patient's left side, we want a button bonded on the upper right canine and the lower left canine. And we're going to use a cross elastic. So a class 2, 4-ounce, 5/16 inch giant panda is actually the one that's clear. Okay, you can use regular elastics too. We're going to have an elastic going while the aligners are being worn in order to help fix that anterior midline discrepancy. And then we're going to use class 2 elastics, maybe just on the right side, because that's where there's more class 2, but it'd be nice to have the buttons on the left as well, just in case as it progresses, we might want to add it on the left side. So that's what these button cutouts are there for. And this is the first setup that we got back. Okay, and I'm going to show you the live setup here. Well, it's not live, it's a recorded version, but I'm going to show you the actual setup. Okay. The first setup came back requiring 30 stages or 30 aligners. And here is a recording that I did in the doctor portal of the actual setup. So I'm going to show you how I analyze and look at these setups. Rather than pushing play, I like to just grab the slider and I like to move it back and forth, because when you push play, everything moves very slowly. But when I move it back and forth more quickly, your eyes can see, as I focus on different parts, I could focus on the back teeth, focus on the midlines. You can see things moving. So you go, okay, on the back, what are they doing on this right side? Is there any distalization happening? Did they apply that rotation that I wanted on that molar? Did they apply those buccal root torque that I asked for? How are they bringing this tooth in? I can see things better when I go at a faster rate. So I like to grab that slider and move it back and forth. And I move it back and forth, and my eye focuses on different parts to see what's going on and how the teeth are moving. Okay. And then I like to look at it from the occlusal view. Now, if you watch this area, you'll see that it's pretty tight when they're bringing this tooth in. It's pretty tight right there. That could be a collision, even though Don asked for there to be no collisions there. It looks like there could be, a collision. It doesn't look like there's a bunch of space to make sure that comes in. And they're even applying IPR to kind of create some space there. Let me go back a little bit. Let's look and see what they did with the expansion. See how there is expansion happening in the bicuspids, and there's a rotation happening in the upper molars. And if you watch the buccal, kind of watch the gum line. Watch the gum line of these teeth, and you'll see that as the teeth expand, that the gum line looks like it's pushing out further. Like the roots look like they're coming out further. We'll see it better from another angle, but you can see that those crowns look like they're getting torqued to the lingual as they're expanding. Okay, that's to prevent those lingual cusps from dropping down. Okay, you can see the expansion in the lower to coordinate with the upper. See the rotations being corrected, and you can focus in on maybe a particular rotation and make sure that it has an engager to fix that rotation, make sure there's space for the rotation correction. You can evaluate the overjet. You can watch the midlines get corrected from this view. Look at how much overjet there is in the finishing position and make sure that it's symmetrical. You can look at it from the lingual side here. When you look at the lingual side, watch the, let me pause it real quick. Watch the torque of the upper molars as I slide this back and forth. And you can see that the crowns look like they're tipping to the lingual and the gums look like they're pushing out to the buccal as we're expanding. So that's where they're applying that extra labial root torque that we asked for to counterbalance the fact that those will want to just tip and those lingual cusps are going to want to drop down. So we're overcorrecting essentially to prevent that from happening. Okay. There's a superimposition tool that's nice to look at when we evaluate the cases to see the starting position and the finishing position and compare them. So here's a still picture of it, but let's look at that in the actual software. So you come over here and click on super, all it says is super, and then it brings up the starting position of the teeth. And then again, you can bring the slider back and forth and you can see the starting positions and the finishing positions. And sometimes that helps you to better visualize, how far did these teeth move? Did I retract the upper incisors or did they go forward? Because I didn't want to bring her front teeth back. And I can look at it from the occlusal view, from the lateral view. So obviously I'm not moving the starting position of her front teeth. They're not going forward or back. And the uppers were going forward slightly. So I'm keeping with what I thought initially, which was, let's not retract her lips. Let's keep them where they are or bring them slightly forward. So that super imposition tool is helpful. So the modification, Amit Lala, Dr. Lala was the one who analyzed that setup with Don and gave some modification instructions. And he said, hey, I need more space before you start moving that blocked out canine 1-3. Okay. In fact, I want you to distalize the upper right where there was a little bit more class 2. I want you to distalize the upper right posterior teeth to open the contact before moving the 1-3. Okay. And he wants more labial root torque added to the 1-2, to the upper right lateral. Okay. He wants more labial crown torque added to the lower left 3. He wants to add a vertical attachment to the lower right 1 to rotate it, and then add attachments to stabilize the 3-6 and the 4-6, so the lower 6s when the class 2 elastics are used, so that the force of the elastic doesn't cause the tooth to move around much inside of the aligner. So then setup number 2 comes in, still with 30 aligner stages, and let's look at what setup 2 looks like and see if any of those things were applied. Okay, not much to see from this view. It looks the same as the previous one. But when I look at it from the occlusal view, let's look at it from the right. We asked for some distalization. So I should see that that molar actually distalizes a little bit. We change the view so you can see a gap opening up between these teeth. And you can actually see that these molars, instead of just rotating, they actually are moving distal. Okay, so let's look from the occlusal view and you'll see some distalization happening and you'll see better space opening around this blocked out canine before that canine starts moving. See the visible space? Now I can see gaps in between these teeth before we start moving that canine. That's going to give you much more predictable treatment because I'm avoiding a collision. Okay. And let's just back this up a little bit. Do you see how let me back it up and pause it right there. So do you see how the upper right lateral incisor, the 1-2, See how that root is off to the lingual, the palatal, more than the rest of the incisors? Well, when you bring this tooth out, the crown's going to want to come without the root. It's going to want to tip out there. So that's why he requested extra labial root torque on this tooth, because he wants, as that crown comes out, he wants that root to go out with it. So he wants to overcorrect or overcompensate by pushing harder on that root to get it to come out to the buccal. Okay, and then you remember there were a couple in the lower that he pointed out that he wanted some different root torque to get better alignment. Okay, so you're going to evaluate, analyze the second setup. Okay, this looks like a better setup because I don't see collisions. Things are moving in a way that's going to work out well. So this was just one change. And then we have a really nice looking setup. The only thing that I'll point out here is for an open bite case, we didn't really do much with the anterior open bite. It almost looks like we still have open bite in the front. So it wasn't really overcorrected to give us overbite in the front. But you're going to see that it ends up working out really well. Okay. And there's a reason for that we'll talk about in a minute. And the reason is because when the aligners are in the mouth in a medium to strong muscled patient, as they bite on the aligners, the thickness of the aligners is relatively thicker in the back than the front due to the wedge shape of our jaw or mandible. As the upper and lower hit first, they're going to feel more intrusive pressure than the front teeth. So just wearing the aligners for a patient who has moderate to strong muscle strength, they tend to intrude their posterior segments as they wear the aligner. So as they bite down with the aligners out, they're going to get more overlap of the front teeth, which is why sometimes in our aligner cases, we end up with a closed front bite and a slightly open posterior bite that we have to deal with in refinement revisions. So actually this case ended up treating out really well without really doing anything for the open bite. Just the fact that it was treated with aligners, and aligners tend to deepen bites, it actually worked out really well. And we'll see that here in just a second. Two other tools that I want to point out to you really quick in the doctor portal as you evaluate cases. One of them is the contact. If you go and click this contact button, it will show you the contacts at the start of the case, and it will show you the contacts at the end of the case. So let me go back here really quick. So is this a real open bite case? Well, there's not really any overbite, but you can see in the starting position that the patient actually has pretty well distributed contacts, pretty balanced occlusion. And every anterior tooth does have an occlusal contact. It's not very big and it's on incisal edges, but it's there. Okay, so she doesn't have a tongue thrust habit or a thumb sucking habit or something that's keeping her teeth from having contacts. Obviously, the canine that's blocked out doesn't have any occlusion because it's completely blocked out, but everything else is an occlusion. And so what's the finishing position in this case? Well, it's what I would want to see. Hang on. Oh, let me go back. I went to a different video. Here we go. What's the finishing occlusion? It's actually what I would want to see on a normal or deep bite case. I want to see heavier occlusal contacts in the posterior teeth and no contacts on the front teeth, because I'm trying to avoid an anterior collision with posterior open bite, which we see fairly frequently with aligners. So actually, to me, this case, the final occlusion was set up for a non-open bite case, okay, with no contacts on the front teeth in the final position. But it still worked out well because that's what aligners tend to do. They tend to deepen bites. So another really cool feature in this tool is you can come over to where it says section. Here, I just show you the lower one first. You can see all the lower contacts to start. Pretty well balanced, got contacts on all the front teeth. And then, so yeah, you come over here and you hit section and it flips over to a view where it shows you the cross section that they're going through. And then it shows you the actual occlusion, because it's hard to tell in a model, like how do these teeth, if I could look inside the occlusion, how are they actually hitting? And so you can run through by clicking on this little arrow, you can see how the little slider drags to different parts of the teeth, and then you can watch the occlusion change here. So see how this slider is going through the teeth, and when you hit contact points, you can see the contacts. And where there's no contact, you can see that there's no contact. And if you really want to look at the occlusion, this really gives you a chance to see what is actually an occlusion. What does it look like if we were to cross-section all of this? It's a pretty neat tool. So as you get into your revisions and your refinements, you can really dial in the bite by using this tool, if you like. The other tool that I wanted to point out to you is down here in the lower left is a graph or a chart that shows tooth movement per tooth. So remember we said in this particular case, like her key tooth in the upper arch is going to be that rotated upper right central. So if I click on that tooth, it highlights that tooth. See here, it says tooth movement table. Because I clicked on that tooth, it highlighted the tooth movement table. And so if you keep your eye down here on the lower right side, as I go from one aligner to the next aligner, you'll see these numbers change. Okay, so I can go one aligner at a time and go, okay, it went from 7.2 to 9 to 10.8. They're moving that at about 1.4 millimeters per aligner or degrees per aligner. And I can actually see how much movement is in the crown versus the center of resistance, so kind of the middle of the tooth, versus the root apex. And this really helps us to understand how much movement's being applied and what the rate or, when it's being applied. So I can see by the end of treatment here, this tooth rotated 27 degrees, okay, which is why it took us 30 aligners to do it, because we couldn't start aligning right away because we had to create some space. And then at the rate of like 1.1 or 1.2 degrees per aligner, it's going to take us, up to 30 aligners. So that's the key tooth that's determining how many aligners it took to fix this case. But it's really valuable to be able to look at every single tooth if you want, click on it and go, how much movement from here to here? How much from here to here? How much on the root apex? How much on the crown? Okay. It's a very useful tool. So here's the superimposition of the second setup that was approved. The rotations are approved. Okay, so here's the starting positions, and Don went through and evaluated the rotations and made sure that he liked all the rotation corrections and that he got the overcorrections that he asked for in the setup. Okay, I already pointed out to you the tooth movement chart showing how much rotation was added to each one of these teeth. Okay, looking to see that he got over correction. So you can see this tooth here was rotated mesially. So as we correct it, we'd want to see a little bit of distal rotation. Like I want to see just a degree or two of almost extra twist where the distal's in and the mesial's out just a little tiny bit. So to the patient, it looks perfectly straight, but to us, we know there's a slight overcorrection there. Okay, so that's key tooth movement. You can click on every tooth and see how much movement they've applied to each tooth. And then you can go back to the staging feature and actually see it demonstrated, like, this tooth moves from here to here, then the aligner's passive from here to here. Engagers go on. Engagers go on at the red spots. IPRs to be done where there's triangles. So we start treating the case. All right, and here we are at aligner number 14. So if we're changing at the rate of every 2 weeks, this would be 7 months of treatment at this point. If the patient's doing excellent and we are changing less than that, maybe a week, we could be as short as 3.5 months of treatment or 4 months of treatment at this point. So how are things looking at aligner number 14? Okay, so patient comes in aligner number 14 and you start evaluating. You go, well, I can see some little gaps between the incisal edges of these lower front teeth and the aligner. Little tiny gap right there. Generally, the fit looks pretty nice. I can tell this patient is using their aligners well. So I might go in here and say, you know what, at this point, let's go and take that little fine interproximal strip, and let me just make sure that there's no binding in between, especially between this contact right here, where it's a little bit of a tracking issue right there. So I'm going to lighten up all those contacts, make sure that there's no binding in there. And why don't we stay in aligner number 14 for 1 extra week? And let's have the patient really focus on using chewies right through this front section. So as many times as she can remember throughout the day, for about 2 to 3 minutes, just put that chewy in there and just bite, 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 up and down, up and down, up and down. And as long as I've created the space, that pumping motion is going to basically force those teeth to fit right up into this aligner just perfectly. Okay, so we could basically make sure that these things get right on track before we keep moving on. You see the buttons that have been placed where we had those button cutouts. Okay, so one tool that there's lots of different buttons on the market you can buy. You can buy clear buttons, you can buy metal buttons that are prefabricated. There's tools out there to create buttons out of composite. Here's one from Dynaflex. Orthotech makes the same thing or sells the same thing. It's a sterilizable handle with clear silicone inserts with lots of different shapes in them, one of which is a button. And you basically prepare the tooth surface as if you were going to bond an attachment, and you fill the little void inside of the silicone insert with packable composite. And then you follow that same protocol that we use for bonding attachments to push this handle with this insert right against the tooth so that the composite comes in contact with the tooth, and then you light cure right through this clear silicone. And when you pull the clear silicone off, it leaves behind a button shape that's bonded right to the tooth. Okay. I've also seen people use, prepare the tooth and use a rubber orthodontic separator, placing it right on the tooth and just pouring flowable composite in there so that it spills over the top of the button of the little rubber donut, and then curing it and then pulling the donut off, and it leaves, something that anything that you can create that will hold an elastic is acceptable. You can put a clear bracket on the tooth that's got a hook on it. Whatever is comfortable for the patient and can hold an elastic is acceptable. Okay, so she's got these buttons in place, and there's cross arch elastics being worn, obviously with the retainer in place at nighttime. Okay, this didn't need full 22-hour wear. This was like, they weren't huge corrections being done. So Dawn suggested that these elastics be worn just at nighttime. And so at this point, we're wearing the cross arch elastic to get the midline corrected. And we're just using the class 2 elastic from the upper canine to the lower first molar on the right side, because that's the side where there was distalization happening. The left side had no distalization happening. And I would only include that, set up for the elastic, but I would only add the elastic if we're seeing excess overjet, or if we're not seeing this side move into a nice class 1 occlusion. But things are tracking really well. You can see the expansion happening in the arch form. So here it says 4 months have gone by. So she's definitely going at the closer to 1 week aligner wear and getting great results with it. So this patient's very compliant. So you can compare what you see in the mouth to what you see in the digital setup at stage 14 and make sure that things look like, they match. So what I see in the mouth, does that match what the setup shows at stage 14? And if the aligners fit the teeth really well, they should match. They would have to match if the aligners are fitting the teeth well. So everything's looking good. It's tracking well. And we just move on with treatment. Okay, so here's the change that's happened from start to where we are at aligner 14 out of 30. You can see there's been expansion. You can see there's been rotation correction. It's not perfect, but we've made a lot of progress. So then the patient comes back in at aligner number 22. Okay, and it may be that Dr. Lucy was seeing the patient more frequent, but these were just the appointments at which she actually took the time to take photos. Okay, and again, aligner number 22, things are tracking really well. If anything, we're looking better, back on track on this upper right incisor. Still some little teeny gaps along the incisal edges here, but the teeth are really moving along nicely, and this aligner's fitting very well at this stage. So again, I might go in and just double check to make sure that all of these interproximal spaces are nice and light. Make sure that the patient is focused on chewies on these front teeth or anywhere where you see little tiny gaps, but really the fit is very nice here at this point. Okay, so now we're 9 months into treatment, 22 aligners. Look at how the bite is already getting deeper. The overbite's looking better. And remember, there really wasn't even anything dialed into the treatment plan to make that, into the setup to make that happen. It looked like there was a little bit of an open bite left in the setup. But as aligners do, the bite tends to deepen in the front as the patient wears them. Okay, so here's where we're at. Things are tracking well. Tray number 30, aligner number 30 comes along. So we're at the end of our first set of aligners at 15 months. And Dr. Galletti tells Dr. McGann, the patient is really happy and ready to finish. I just thought I'd check, see if you see any other issues. Otherwise, I'll go on to retention. And Don says, wow, beautiful. The only thing I see is the black triangle on the lower central incisors. You could do some IPR and close that, but that could reopen or be a problem to close. I love the case as finished now. Congratulations to you and your patient. Fantastic work. I'm proud of you and your accomplishment. Dawn, please have Alicia wear the retainers, because now we're going to clean off all of the teeth and order retainers. Have her wear the retainers as she did the aligners for 22 hours a day for 4 months, then change to every night for 6 months, then 2 to 3 nights per week for another 6 months. If they are tight when she installs the retainers, then wear them more hours per week. If not tight, then she can taper off until 1 night per week forever. We all have slightly different retainer preferences. Okay, what I do in my practice is I tell the patient that now we've moved into the retainer stage. I have them go the first month just wearing that full time. After the first month, I want them to basically take them out in the morning when they wake up and just go throughout their day without their retainer in place until they start to feel with their tongue, because they can sense it when things start to shift just a little bit, and then put their retainer in for the rest of the day, wear it that night, and then go the next day. So the first day they might go from, they wake up at 7 and they go until 10 o'clock in the morning before they feel like their teeth have shifted a little bit. And at 10 o'clock, they put their retainer in and wear it the rest of the day and wear it that night. And the next day they take it out at 7. And the next day they get until 11 o'clock. And then the next day they get till 12 o'clock. Okay. And slowly we're reducing the number of hours during the day and increasing the number of hours when they're not wearing their aligner during the day or their retainer. And I do this to encourage the teeth to start to settle. Because as long as you're wearing the aligners 22 hours a day or the retainers 22 hours a day, there's no settling happening. And so, it's difficult for me to kind of adjust the occlusion and make sure that everything is getting into maximum intercuspation, settling into a nice intercuspation, because the aligners are in the way, they really can't settle. And so by doing this titrating where I'm giving them more and more hours during the day with them out, they're swallowing, they're functioning with the aligners out, they're starting to get their teeth to settle so that I can kind of monitor that during the 6 months. And then my protocol is I tell the patients, once we get to where your teeth aren't shifting during the day, we have a nice established occlusion. I want you to wear your retainers every night for as long as you want your teeth to be straight. And I do that because I find that if they wear them every single night and it just feels normal to them to go to bed at night with their retainers in, they don't grind as much on their teeth, they protect the restorations more, and it's just a habit where their teeth will always be straight. But if they only put them in sometimes at night, they give themselves excuses, they forget. It's just not a nightly habit or routine. And so they just don't do it. It's like brushing your teeth 2 or 3 nights a week or 1 night a week. It's like, well, which one did I do it? And so, although I think you can be successful with the, 2 to 3 nights per week, or depending on how they feel when you put them in my experience, that tends to allow the patients to just get out of the habit of wearing their aligners at night or their retainers at night. And if they just always have them in every single night, it just becomes a lifelong habit for them. So see what works for you and your patients. There's different ways to approach that. So here's the finish, a really beautiful finish. Really nice smile. I mean, I would be very, very pleased with this in my practice. Her profile looks the same as it started. Her smile looks fabulous. Okay, so she looks like she's matured and grown up a little bit. But start smile to finish, it's just, there's nothing to be critical of there. It looks amazing. It looks great. It's a really nice job. Here you go with the photos. So here you can see, Dawn was pointing out this little black triangle down here, which when the patient, for them to see that, they'd probably have to take their finger and pull their lip down to visualize that. So it's probably not as offensive. If you did close that up, if you did some IPR right here to close that up, you could end up with a little bit of excess overjet. So you might end up having to do a little bit of IPR in the upper as well to also retract them a little bit to keep the overjet ideal. So I like that the patient and the doctor were willing to just leave this alone and keep a nice ideal overjet. At this point, you could go in with a little softless disc and just change that corner just a little bit to match the other one. But very nice. I'd be really thrilled with this. And look at how well the bite comes together in the front. We literally have ideal overbite, ideal overjet, and a very nice finish. Oops, there is the lateral view, start to finish. Okay, you can see there's still, it looks class 1 to me on the right, on the left side, and just a little hint of class 2 left on the right side, because the right side started off with that, 2 to 3 millimeters of class 2. But when you look at the interdigitation, it looks really, really nice. Okay, start to finish. See the expansion. And because of all of that labial root torque that was added, you can see that the upper posterior teeth are not flared out to the buccal. Okay, that was well controlled. So even though there was obvious expansion of the arch form, and again, this isn't going to happen on all your adult patients. This patient was 17 years old. She's young. Her body's able to remodel. And so we saw good result with her expansion. Okay, she had nice large dental alveolar process that had the width to allow that to happen. So that's not going to happen on every single one of your cases. You may have cases where you wanted that and didn't get it. But in this case, that rounding out of the arch looks really, really nice. Rotations look really good, really well corrected. Okay, did we get the overcorrection? Did Don get the overcorrection that he wanted? It doesn't look overcorrected, but it looks really nice. Could that have been from the setup not having the overcorrection, or from, the aligner having some weakness? Did we get the overcorrection in the lower? It actually looks like we do have that slight overcorrection in the lower from the way it started to the way it finished. So it looks like we got the overcorrection in the lower and not so much in the upper, but the upper looks really good. It looks straight. So as long as she wears the retainers, you're going to always have nice straight teeth up there. Okay, start versus final ceph. You can see in the ceph that slight open bite tendency. Remember, we did have little contacts everywhere, but there was a lot of areas where there weren't contacts. And in the final, you can see proper overbite, overjet. There's a very nice relationship in the final position. Start versus final ceph. You see the nicely aligned roots. That's because all of the marginal ridges were aligned properly, so that left all of the roots well aligned. Okay. Probably need to take out the third molars. In fact, remember how we distalized a little bit on the upper right side? It wasn't very much. It was like a millimeter. Okay. If I was distalizing more than that, I would have wanted that upper molar extracted, the upper 8. I would have wanted that extracted because I would want the room, I would want the recent extraction site with all that good cellular activity to allow that distalization to happen. But it was only a very small amount of distalization, so it wasn't really impacted by having those 8s present. Comment here online that they would like to have seen the lower black triangle treatment since she's young. And yeah, some of you may have gone ahead and treated that black triangle in the lower arch, which would have been completely acceptable. So overlays. Okay, thank you, Don, for giving us overlays here. SN overlay at S from start to final. Start is in blue, red is the final position. You can see slight forward movement of the maxilla and the mandible. Okay, did the aligners do anything to create that? I can't imagine why. Maybe a little bit of growth happened there. We did have some class 2 elastics going, so that may have been the reason why there was a little bit more advancement of the lower of the mandible, just maybe a slightly forward position compared to where she started, but minimal changes. So it looks like the mandible went forward and up just a little bit. Remember, aligners tend to deepen the bite by intruding the back teeth. So if the back teeth intruded, that would allow the position of the mandible to come up and forward just slightly, which may be why we see that here. I can't really account for any reason why the maxilla would come slightly forward, except for growth. Maxillary overlay from start to finish. Upper incisor came forward 2 millimeters and was extruded 0.5 millimeter. Okay, I don't really remember seeing anything in the setup that was extruding those upper incisors, but definitely got some intrusion of those posterior teeth. Again, I didn't see intrusion of the posterior teeth, but the aligners tend to do that. And we got that 1 millimeter of distalization. And in the lower arch, the molar stayed where it started and the lower incisor came forward just a tiny bit because there was that little tiny bit of crowding. And also we had class 2 elastics in the mouth. And there was very slight extrusion of that lower incisor. So even though I didn't see anything in the setup that necessarily was extruding those upper and lower incisors, in the overlay, it does show that there was some extrusion that happened, but her bite finished very nice. So I kind of mentioned that I didn't see a lot of things done to correct the open bite, even though it finished really nice. And if I had had a real open bite where there was a tongue thrust habit and there was clearly no contacts on any of the anterior teeth, what are some of the things that I could have done? Aligners do tend to deepen bites by intruding the posterior segment, as we've said. So that's going to be a given. And that's why it worked well in this case, because it was just a minor adjustment that was needed in the front. So overcorrecting, finishing with 2 millimeters of anterior overbite with occlusion on the incisors and with posterior open bite or no occlusion on the back teeth would be an overcorrection in a case where I actually wanted to fix a true dental open bite in the front with no contacts. So I'm going to show you a setup in just a minute where there's, and then how much I do that, how much I open the posterior teeth will depend on how much anterior open bite I have. I definitely will always use a handpiece to remove any premature contacts or plunging cusps on upper molars. The more tooth mass that I can get rid of in the vertical dimension on the back teeth, the more that the jaw will close. So extracting eights, especially on the weak muscle patients, they don't bite enough to keep their back teeth from over erupting. So when those eights erupt, they can literally over erupt. And sometimes you'll see patients bite and the only thing they're hitting is their eights or their eights and their sevens. So the third and the second molars and everything else is open. And the way it got like that is they don't ever bite their teeth together with any force. And so those back teeth just over erupt. It just takes a tiny bit of over eruption to open up the whole entire front. So extracting eights, doing an enamel removal on some of the cuffs or the high contacts on the sevens or sixes can really help, correct that almost halfway before you even start. Pay attention to the transverse dimension of the upper. So if it's a little deficiency in the upper and they're kind of hitting buccal cusps on buccal cusps, then make sure you expand enough in the upper to fix that problem and also add that labial root torque that we saw to make sure that the lingual cusps don't drop down and open the bite. If you're trying to correct an open bite, encourage the patient to exercise their jaw muscles, to clench on the aligner, to clench on the back teeth as much as possible. As they strengthen their jaw muscle and as they put pressure on those back teeth, like as much as they can remember, say all the time, every time you can think about it, I just want you to clench your teeth together, okay? And that will help to close those more moderate open bites and help them keep it closed because they've increased their jaw strength and it's become more normal for them to bite back there. Okay, I always check for good nasal airway. If the patient can't breathe through their nose, if they have constriction in their nasal passage, even if I do get their bite closed, they're not going to become a nose breather if they can't breathe through their nose. They're always going to go back to mouth breathing and then tend to want to reopen their bite. So a referral to an ENT to do whatever needs to be done, whether it's removing adenoids or putting them on some medication to get rid of swollen tissue, whatever needs to be done to create a nice nasal passageway, a nice airway, can help get these bites closed and stay closed. And also working with a myofunctional therapist to learn how to use their tongue and swallow properly will really help. If it's more of an open bite, I will consider placing attachments. So I literally have them put an attachment on the occlusal surface of the teeth that are in occlusion, and they line them up so that when the patient bites, they're hitting those attachments. I don't fill those with composite. I don't want composite on the occlusal surface of the teeth. I just want a bump, an extra bump in the aligner, as if there was an attachment underneath, so that when the patient bites and clenches, they're hitting some extra thick material back there, some extra elevation, and that allows them to put more pressure on their back teeth to help intrude them. And then I'm going to put horizontal engagers on the upper and lower anterior teeth to anchor those front teeth to help me as I apply intrusion with the aligners on the back teeth. Okay, so in this case, we didn't actively apply intrusion pressure to the back teeth. It just happened because of the way she was functioning. But if I had more of an open bite, I would actually want to see the back teeth being intruded in my setup. And then I would, possibly back that up by having these attachments on the occlusal surface. So pay attention to the upper incisor display and gingival display. If it's already excessive at start, I wouldn't want to extrude those front teeth and make it worse. I would just want to focus on the intrusion of the back teeth. If it's not excessive, then I would allow some extrusion of the front teeth plus intrusion of the back teeth. So let me just demonstrate that. And these are the last two slides before we finish. Thanks for hanging in there, guys. Okay, so here's an example of this case, but set up with a true open bite in the front where there's obviously no contacts. There's a tongue thrust going on. Okay. So in a case like this, where I have open bite in the front, and it generally looks something like this. You'll have open bite that kind of gets less and less as you go, and most of the occlusion is on the posterior molars. So how I would want to see the case finish, I'm just going to use some 3D controls here to basically show you how I would want the case to finish. If the patient's not already too gummy or showing too much of their front teeth, I would want extrusion of my upper and lower front teeth until I have 2 to 3 millimeters of overbite. Okay, so ideal overbite in the front with contacts. Okay, and then in the back teeth, the ones that started out in occlusion, I'm going to want to see the back teeth that started out in occlusion to start to be intruded. So my overcorrection is I'm going to finish with open bite in the back that gets progressively greater because it's harder to intrude these back teeth. Okay, so I have ideal bite in the front, open bite in the back. And I would accept this as the final target position for my open bite case where I really need to close an open bite. Okay, and we need to keep in mind that these aligners, this setup doesn't represent the final position of my teeth. It represents the shape of my aligners. And the shape of the aligners, when they put it in the mouth, represents the forces being applied to the teeth. So in a setup like this, I would have horizontal engagers on all these front teeth because I'm extruding them. And I'm also anchoring the aligner to these front teeth so that it stays anchored as I start applying intrusion force on the back teeth to get them to intrude. So the shape of this aligner is extrusion force on the front teeth, intrusion force on the back teeth. Okay, and so every time the patient comes in, I'm having them take the aligners out and I'm having them bite down. And at some point, as the aligners apply this type of pressure, I'm going to get to a point where when the patient bites, I actually have the bite closed. And at that point, I don't want to apply this pressure any longer. So at that point, I would take a revision or refinement new scan, and I would get new aligners that are no longer trying to intrude the back teeth and extrude the front teeth. At this point, I would now have the correct bite and just work on fine-tuning the case. But until I get the bite closed, I want this overcorrective force being applied, this extra strong intrusive force applied to the back and this extrusive force applied to the front. So if I had a patient who had excess gingival display and excess incisor display, and I did not want to intrude the front teeth, I did not want to extrude the front teeth and make the gingival display worse, I would finish with a setup that looks like this, okay, where I did not fix the open bite in the front. All I did was intrude the back teeth. And so the final target position, if you look at it all the way around, it looks as if there's open bite all the way around. And it looks like if the patient were to bite together, everything would match up and come together. And the technician will actually give you one final stage where it's called a virtual jump. So there will be one final aligner stage where they go from this open bite look. Let me pause this here. So they go from this open bite look that looks open all the way around, and they'll do one final stage, which is not actually an aligner stage. It's just a stage where they show you that, hey, when I virtually jump this together, essentially when the patient bites down, you can see that everything's going to fit. Okay, so this would be an example of a case where I don't want to apply a lot of extrusive force to the front teeth. I'm still going to put horizontal engagers on all these front teeth so that I can lock the aligner onto those front teeth. And I'm only going to apply intrusive force to the back teeth. Okay, now we know anytime you apply forces in the back, you're going to feel that in the front. So there will still be some extrusive forces on the front teeth, but not as much as the setup and where I actually allow them to extrude those into ideal bite in the front. Okay, so these are two different types of setups that I would look for in a case that has more moderate open bite compared to the one we just looked at. And my voice is about gone, and we've spent a lot of time together. So thank you guys so much for spending time with us. I hope that you have seen some things that were interesting to you and that you learned something and that you're intrigued by the progressive aligner software and the progressive aligner features and material, and that you'll be excited to try a case with progressive aligners and see how good these stagers and designers are and how high quality this product is. We're very excited about it. So thank you guys, and thank you, Don, and thank you, Amit, and thank you, Lucy, for these slides and this education. And thanks for being with me, guys. I will go ahead and take questions if any of you guys have questions.
Well, thank you, Colin.
So, yeah,
that was fantastic. That was
do you have any other
fantastic.
comments? Anything you want to add, Don?
No, I think you did a fantastic job. And you added a bunch of all that video stuff. That was fantastic. Great.
It's
so
nice
talented.
to see it. It's nice to see it in action. Yes. Anybody have any questions? I went really fast on a lot of things, and like I said, we can't cover everything in every one of our webinars here, but every 2 weeks we're going to have one of these. We invite you to join us 2 weeks from now. It's actually going to be Wednesday next time instead of Thursday, but same time. So just a little bit less than 2 weeks from now. And I'll be doing that one. And then 2 weeks later, Don will be teaching. I think Don's going to be teaching at a time that might be more convenient for the Australians and the Europeans. Have we decided on a time yet, Don?
I think I put out 3 proposals. I haven't heard back exactly when's the best. So
could be late Friday night or early Saturday morning or something. But anyway, we'll announce those times as they become available and kind of change it up. So some of the people that are sleeping right now and just watching the recording will get to see the actual presentation. So thank you guys for all your comments on here. It felt very long to me, so I'm grateful that you took the time to be with us. And
it was actually exactly what you said it was going to be, 2.5 hours, I think.
Well, we're at about 2 hours and 45 minutes, but yeah,
well, that's close enough.
We had 90 slides, so I was like, all right, this is going to go 3 hours for sure. All right. All right, good. Thanks, guys. I don't see any questions coming through. You're welcome to unmute yourself if you want to ask a question or type it in. I'll give you guys a minute or two if you want to ask a question. I'm happy to explain a little bit more or go into a little bit more detail on something if you want.
Thank you, Collins. You did a great job. You're such a good speaker.
Thanks. I'm
You're
going
going to be a tough act to follow.
You're going to do great. I'm going to put my email address in here for you guys that are in the chat in case you want to email me with any follow-up questions. Collins@posortho.com. Easy to remember. Collins@posortho.com. So if you have any questions as you're submitting cases, we'd love to get you guys started on some progressive aligner cases. Those of you that are in the US and can use them right now. Those of you that aren't, hopefully that's really soon in the next month or so. But as you're submitting it, this is a new product. We may have little glitches here and there in the process. So if you run into any frustrations or concerns or questions where I could help you, feel free to email me. And I'd love to just help you through anything. There are lots of great consultants and mentors available if you want to sign up for consulting or mentoring. Please use the coaching service if you want to ask questions before you start the case to help you decide whether or not you want to treat it or help you sell the case. All right. Any questions? I really appreciate you guys being here. It was really meaningful to have all of you here. So please enjoy your evening or your morning or wherever you're located. And I look forward to being with you in a couple of weeks. Go catch a big fish, Don.
Adios.
All right.
See you.